you should ask about an associations, because these are the most important part of the history taking. History taking is easy, and take the general approach. Don't look for case by case. Case by case, you may lose something. So take it as a general approach. General approach, associations are very important. Associations, you should ask about fever, loss of vision. You should ask about lumps and bumps, fatigue, skin rash and skin rash on sun exposure, polyuria and polydipsia, oral sores and private area sores. So these are the associations. Any change in the body weight, this should be asked in any scenario. Whenever there is debilitating diseases, you should ask about travel history. You should ask about any family history. For malignancy, you should ask about manifestations of anemia. So very important to just be prepared in a general approach. General approach, even if you have never practiced cases or never had role playing, you will be able to approach the case and ask the proper question. Be prepared by as much as you can symptoms, as much as you can differential diagnosis, as much as you can signs for clinical examination in case of UK. And this is the best way to approach any case in the exam, and you will reach a diagnosis and you'll be able to discuss the case with the exam. This is my advice. It's the easiest approach and it's comprehensive. And here you have the knowledge, the background, the basic knowledge, which is very important to approach any case. I will give you some Telegram groups just to join. These are the Telegram groups, and you will find all the needed information in these groups. Because this is the easiest and the best way to study. Here in these groups, these are specialized groups, and in these groups, you will have all collected information and resources and everything. You will find one group for all videos, all videos. You will find here this group for all videos. All videos of past tests and other videos are here in this group, and you will find one group for cases. So in this group of cases, you will find all the cases needed for the exam, but actually I have a problem with the connection for the time being. Here, all the books. Here, this one, you will find all the books needed, all the books. And you'll never need all the books, but at least you have a reference for all the books for clinical exam. All the books are here. And then you will find spot diagnosis. You will find some cases for spot diagnosis. These cases are very important because you will have the diagnosis and you should confirm the diagnosis in a spot diagnosis, and you should, after confirming the diagnosis, you should go for associations and complications. Investigations, communication, you will find all groups. So this is the best way to study. Here you will find the history taking, you will find the differential diagnosis. The differential diagnosis, you will find all cases: bloody diarrhea, ataxia, headache, loose motions, vomiting, diarrhea, shortness of breath. And you'll find some files with collective information: xerostomia, handshaking, erythema nodosum, loose motions. So all the important differential diagnosis and scenarios are here in history taking group. So I hope, inshallah, you will join these groups, which will make your life easy in the exam and help to save time preparing for the exam. So uh, I will go for your questions. If any questions, please ask. Uh, okay, some groups you may need some adjustment. I will do it. Some adjustment meaning that to open the files of previous to you're joining the group. So I will make sure that all the files will be shared. And if you are not able to find any files, okay, go for the general one. Here there is one general group. You will find all. This is the general groups. The general group, you will find all the files and all the media and everything. Spot diagnosis. You will find everything there. In this group, you will find all the files, even the books and everything. This is the general group. Here, 1,725 files are there in this group. So go for this group and make sure to find all the files. I want to make sure the connection is okay. Okay, so this link for the general group, and you'll find all the files. If you are not able to reach any file on other groups, you go for this group. You will find all the books and files and everything. And actually, here I put all the files. If you are looking for any file which is not clear or not appearing, or you want it, send to me, and I will send you the file even in private. So don't worry about the resources, because these resources are the easiest way to study for the exam. For the time being, if you have any question, please ask. Okay. So actually, these are important files because they are easy to read and easy to understand and easy to memorize. So these files are made easy, and I hope, inshallah, will help you in the exam. If any question, please unmute and ask. Okay, so I will save your time. What I want to tell is today is long day. We'll go through all the long clinical consultation cases on past test, and we'll record and we'll share the recording with all of you. But the point is that don't depend on the recording. because we usually, and from my experience, we have a lot of recordings, a lot of files, and we don't read and we don't listen. So most of us, we have passed tests and we didn't see the videos all. So the best thing to do is to see the videos, and then after that, we'll comment and we'll discuss some important cases. But for the time being, I want you to see all the videos. It's a good chance to share this together, because this is actually, if you have any question, ask and leave your question and we'll answer. Don't worry about answering. I will answer any questions. So the point is that we know and we are familiar with the clinical examination steps as we did in the neurology. We are familiar, we should be familiar with the clinical examination, and we should know how to approach the case. So approaching the case is very important, and you can add from your knowledge and experience, you can add more. So this is not the standard, but at least we'll get knowledge about the most important cases in the exam and the approach to those cases. So we'll go now for the videos, and be patient with me. If you are free and you have time, continue. Get some coffee, get food, whatever you are doing, do it, and we'll share the videos together and we'll see the videos together in order to comment and discuss the cases later on. And I will send you the related files of these cases. I will send you the related files in order to read for these cases. Okay, so let us start. And I hope, inshallah, all will be patient and stay together to see all the videos. It's a long day, and be prepared. This is a case of ankylosing spondylitis.
Hello there. My name's Gavin Britton. I'm one
You
of the
can
medical
hear the
doctors in
voice?
clinic today.
Hi, Gavin.
Is it Mr. Morris?
It is, yes.
I've been asked today to talk to you about breathlessness. Would that be okay?
Yeah, it's fine, yeah.
Can you tell me a bit more about this?
You can see the video
It
and
started
hear the
about a
voice.
year ago. I noticed that
Yes, Doctor.
when I did some
Okay,
I
thank
like
you very
being
much,
active,
Doctor.
Yes, Doctor.
walking. After I did some walks, I started getting breathless, just tight around the chest. And I get a bit of sweating now and again, a bit more sweating than usual anyway.
Fine. And can I ask, you noticed it when you were walking. Has
Yes.
that restricted you from being able to enjoy walking at all?
Oh, it is, yeah, because I know it's got, over the years, it's got worse and worse. So
Yeah.
I can do less and less, as it were, before it actually starts.
And presently, how far can you walk before it starts?
Oh, about a quarter mile now.
And previously?
Oh, I could walk for miles really before, yeah.
Fine, okay. And if I ask you specifically a bit more about this breathlessness, have you
Yeah.
noticed a cough that goes along with it?
No.
Have you noticed any chest pain
No.
or back pain?
Well, I've always had back pain for ages now, about 40 odd years.
Okay.
Yeah. So, but it's no more than it was before, though.
Fine. I might come to that in a second,
Okay,
if that's okay. But in terms of the breathlessness, have you noticed any fevers or night sweats?
No.
Any lumps or bumps in your neck that you might have noticed?
No, nothing like that.
Any weight loss or change in clothes size?
No.
Good. And any cold or flu-like symptoms?
Well, I know the cold now and again, but no, nothing more than that.
Nothing currently, though?
No.
Good, fine. Just to come back to this back pain that you mentioned.
Oh, yeah.
When did that start?
I say it started about 40 years ago.
Okay.
Yeah.
And can you tell me a bit more about that?
Well, I started getting pain, in the lower back, went down the buttocks, going to the back of the buttocks. So I went to see the GP.
Okay.
They put me on ibuprofen,
Okay.
and that seemed to let me cope with it at the time. Yeah, so
Fine. And is this back pain worse at any particular time of day?
it tended to be worse in the mornings when I'm getting out of bed.
Fine.
'Cause
And
I got very stiff, so sometimes it could be a while to actually straighten up.
okay. And does anything else make the back pain worse, such as exercise?
A bit of exercise, does help. Yeah.
That helps.
Oh yeah.
And what about rest? Does that help or?
Well, not really. I mean, I'm better when I'm moving about rather than sitting down
Okay,
or
fine.
sitting around.
Sure. And can I ask, it's obviously affected your back. Has it affected any other joints?
No, just the back.
Just the back, fine. In terms of other medical problems, have you been given any other diagnoses?
Yeah, I've been diagnosed with Crohn's disease.
Okay.
Yeah.
And have you had to have any operations or treatment for
Yeah,
that?
I had 3 operations back in the 80s for those.
Okay. And
On the stomach, yeah.
what operations were they?
Right hemicolectomy, I believe it was called.
Fine. Okay.
Yeah, and then I had a temporary ileostomy when the reversal.
Fine. And are you on any treatment for the Crohn's disease currently?
No, that seemed to settle down once they cleared up. Settled down.
Fine. Okay. So we'll touch on that again in a second.
Okay.
Is there any other medical problems you have?
No, that's about it.
Okay. And currently, you mentioned that you take paracetamol and ibuprofen. Do you take any other medications?
No, that's it. That's all I do.
And do you have any allergies?
Penicillin. This is going back about 50 years ago now.
Okay.
I think it came out in bumps at the time,
Fine.
kind of thing.
Do you recall if you had any swelling of the mouth or breathlessness at the time?
No, I can't remember.
Okay, fine. Just in terms of other symptoms that you might not or may or may not have noticed, your bowel habit, how's that currently?
Well, I suppose I go more often than most people, but it doesn't seem too bad to me now.
It's quite well controlled.
Yeah.
Any mucus or blood in the stool?
Not that I've noticed, no.
Any abdominal pain?
No.
Have you noticed any episodes of bowel or urinary incontinence?
No.
And when you do visit the toilet and use toilet paper, is the sensation normal?
Yeah.
Yeah, that hasn't changed.
It doesn't change, no. Not noticed.
And the back pain, is that worse at night at all?
Well,
So, like waking you from sleep, for example?
no, it keeps. No, I don't wake up in the night. As you mean, no, not
Good.
very often.
Okay. And the breathlessness, do you find that's worse if you lie flat, for instance?
Well, I get breathless more when I'm moving
Just
about.
moving about, but not lying flat.
Not lying flat, no.
How many pillows do you use currently?
Sometimes 2, sometimes 3.
Is that an increase on previous?
Well, yeah, I've gone to 3 recently. Yes, over the past year again.
Okay, fine. In terms of smoking, have you ever smoked?
No, I haven't. No.
Never smoked.
Never smoked. No.
And I understand this has affected your mobility quite a lot. Do you work currently?
Oh no, I'm retired now, but I did used to work. Yeah.
And did the back pain or breathlessness affect your work?
Well, I say I controlled it with the drugs.
Sure.
So that kind of got me through, and I just kind of got on with it.
Okay. And what is it that you did?
I was a builder.
Okay, fine. And you were able to carry on working until what age was that?
Oh, got an early time when I was 60, just early 60s.
Okay, fine. Can I ask, is there any medical problems that run in the family?
My mother did have bad arthritis, mainly in the joints, the knee and the hands in particular.
Is there any lung or respiratory conditions that run in the family?
No.
Good, okay. I'll just ask you just a few brief more questions.
Okay.
Have you noticed any changes in your eyes, such as grittiness or pain?
No, nothing really.
Any changes with the tendon at the back of your leg, your Achilles tendon? Have you ever noticed any problems with that?
No problems with that.
And have you ever had investigations from the GP in regards to your heart, or after having any special investigations?
No.
And have you visited the GP regarding this back pain previously?
Well, no. Well, I said a long time ago, but I don't like going to doctors and things like that. So I try to stay away from them. So, but yeah, not for 20 or 30 years I wouldn't have thought I'd been to a GP.
Fine, okay. What I'd like to do now, if it's okay with you, is examine your back and your movements, and then I'll have a listen to your heart and your chest, if that's okay.
Yeah, that's fine, yeah.
So if you can slip your top off,
Okay.
and we'll start from there.
Okay.
And just stand comfortably. And can you turn around for me? And I'm just going to have a feel across your spine. Is there any pain at the minute?
No, not at all.
Please do let me know if this is uncomfortable.
I will, yeah.
Just going to have a feel at the bottom there. Is that uncomfortable at all?
No.
Good. And if you turn back around for me, could I have a look at your hands? Is there Discomfort in your hands at all?
No, no.
Please do let me know if this is not comfortable.
No.
Good. Okay. Having a look at the movements in your neck now.
Okay.
Could you bend your chin towards your chest and head up towards the ceiling? And then ear to one side and then the other side. And if you turn your head to one side and then the other side. Okay. And then standing back up, if you slide your hand down one side and the other side. Okay. And if you can bend forward to touch your toes and back up the other way and arch your back backwards. If I can have a look at the distance between your head and the wall, if I can ask you to stand right up against this wall for me. And just lean your head back as far as possible. Okay, thank you. And lastly, I'd like to do a similar thing on your back, if I can ask you to turn around again.
Right.
And if you can just lower your trousers ever so slightly. That's it, that's fine. Thank you. Okay, I'm just going to place a mark with some pen on the bottom of your back.
Okay, right.
And if I can ask you to bend forward, I'm just going to measure that again. Thank you.
Right.
If I can ask you to take a seat on the bed for me. And just pop your hands onto your hips. Step back. And can I have a feel of your pulse? You can rest that hand down. Do you have any pain in the shoulder?
No.
I'm going to lift your arm up. And rest your arm down. Are you able to peel one eyelid down? Okay. And open your mouth. Tongue up to the roof of your mouth. And relax. And just turn your head to the left as much as possible. Do you have any pain in your abdomen?
Nope.
I'm going to press on your abdomen.
Okay, right.
I'll have a listen to your chest now.
Right.
Just over. Sit forward for me. Take a breath in and out and hold it out. Breathe away. When you're ready, take a breath in and out and hold it out. And breathe normally. Hold your breath when you're ready. And breathe normally. Hold your breath when you're ready. And breathe normally. Thank you. And keep sitting forward and I'll have a look at your back.
Okay.
feel of the bottom. If you take a breath in and out. And again. And out. Have a feel of your neck. I'll have a listen to your back. Could you cross your arms? And breathe in and out. Feel at the bottom of your back. And relax. Just have a look at your legs.
Okay.
Do you have any pain in the backs of your legs?
No.
And any pain in the feet or ankles?
No, none at all.
I'll just have a feel. Do let me know if this is sore.
No, that's fine. That's fine, that would.
To complete my examination, I'd like a full set of observations. That concludes my examination, Mr. Morris.
Right.
To take things further, I'd like to do some investigations.
Okay.
Firstly, I think the long-term back pain you've described in clinic today may well be an inflammatory condition called ankylosing spondylitis, and I'd like to investigate this further.
Right.
It could be that the breathlessness that you've described is associated with that condition.
Yeah.
So what I'd like to do, if it's okay with you, is some blood tests, some x-rays of your chest, spine and pelvis, an ECG, and some pulmonary function tests. After those initial investigations, I'll see you back in clinic today, but we may well consider doing an echocardiogram and a CT scan after that.
Okay.
Do you have any concerns?
No, not at the moment, thanks.
Thank you very much.
Thanks very much.
Can you summarise your history and examination findings for me?
This elderly gentleman presented with a progressive one-year history of breathlessness in association with a reduced exercise tolerance on a background of chronic back pain and early morning stiffness. The examination revealed an underlying diagnosis of ankylosing spondylitis, and this is signified by the marked reduction in spinal movement across the entire axis of the spine, as well as a increased wall to tragus measurement and a positive Schober's test. On cardiorespiratory examination, important findings were inspiratory crepitations at the apices, and important negatives were an absence of any murmurs heard on auscultation. There was also an absence of any signs of fluid overload.
So what do you think the causes of breathlessness in this gentleman are then?
So I feel the underlying diagnosis would be one of apical fibrosis secondary to his ankylosing spondylitis.
Are there any other causes in ankylosing spondylitis that could result in breathlessness?
Other important differentials for this gentleman would be anemia as an underlying cause of breathlessness, and this may be related to a microcytic anemia secondary to non-steroidal use, or anemia of chronic disease. Other differentials would include a mechanical restriction secondary to fusion of the spine, causing a restriction. And I'd also like to consider malignancy given the progressive breathlessness and the night sweats in the history. Lastly, I would want to consider cardiac causes such as aortic regurgitation, which is a known association with ankylosing spondylitis, although there were no signs of this on examination.
What investigations would you do?
So initially, I would want to perform some blood tests, and I'd start off by checking this patient's inflammatory markers, looking for evidence of disease activity in terms of the ankylosing spondylitis. I'd also want to check full blood count and baseline for future treatments. After that, I'd like to request a HLA-B27, And I'd also like to perform x-rays of his spine and pelvis, looking for evidence of sacroiliitis and fusion in the spine. Should these x-rays be normal, I may well want to consider other imaging modalities such as an MRI scan of the spine. In terms of the fibrosis, I'd like to request a chest x-ray, looking for any other causes of breathlessness, and I'd also like to request pulmonary function tests. Following this, I may well consider further imaging such as a high-resolution CT.
What pulmonary function abnormalities might you expect in this gentleman?
I'd expect to see a restrictive pattern. That is a reduced FEV1 and reduced FVC with a maintained ratio.
Is there any way to tell the difference between the pulmonary fibrosis which you suspect he has and a mechanical restriction due to the thorax being fused?
So I'd look closely at this gentleman's transfer factor. In mechanical restriction, I would expect the transfer factor to be well preserved due to the underlying normal lung. However, in pulmonary fibrosis, I'd expect the transfer factor to be reduced due to the underlying damaged lung.
What treatments are available for ankylosing spondylitis?
So I'd want this patient to continue on his regular analgesia, and I may wish to escalate his regular ibuprofen to other non-steroidals such as naproxen as appropriate. Following this, dependent on disease activity, I may wish to consider this patient for further immune modulating therapy such as sulfasalazine and methotrexate. For patients with refractory disease, it may well be appropriate to consider further immune modulating treatment in the form of anti-TNF agents.
Do you know any other non-pharmacological treatments for ankylosing spondylitis?
It would be important for this patient to have a physiotherapy and occupational therapy review, and other treatments such as hydrotherapy have been proven to be effective in ankylosing spondylitis. I'd also want to ensure any patient with ankylosing spondylitis that does smoke that they receive appropriate smoking cessation counselling due to the close association with disease activity.
Do you know of any pre-treatment considerations before considering anti-TNF treatment?
I'd want to ensure this patient has received appropriate immunisations and also screen for latent or active tuberculosis.
Thank you.
Thank you.
This is a clinical consultation station of a gentleman with shortness of breath and a long history of back pain involving a real patient with obvious physical signs leading to a diagnosis of ankylosing spondylitis, but it could involve an actor with no abnormal signs and the diagnosis may not be as obvious. The cause of the breathlessness is a little more complex with a wider differential diagnosis. The history should be thorough and methodical, initially exploring the wide differential diagnosis of back pain. These include mechanical, traumatic, inflammatory, neoplastic, or even potential infective causes. It is important to exclude symptoms of cauda equina, such as bowel or bladder dysfunction, saddle anesthesia, or numbness and weakness in the legs. The history should be directed at teasing out the exact area and character of the back pain, the chronicity of the symptoms, any relation to exercise, morning stiffness, and any nighttime wakening. A recent or previous history of trauma is important to exclude. Inflammatory causes including psoriatic or inflammatory bowel disease associated spondyloarthropathies. Therefore, eye symptoms, rashes, or bowel symptoms should be asked. A family history of back problems or inflammatory bowel disease should also be asked. Weight loss or night sweats may point towards a neoplastic cause, and fevers more towards an infective cause. Risk factors for TB should be considered. In this more obvious case of ankylosing spondylitis, symptoms of shortness of breath should be asked, considering the potential association of cardiorespiratory problems. The examination should initially focus on the back, with inspection for obvious deformity, then palpation for any tenderness over the spine and the sacroiliac joints. A full range of movements of both the back and the neck should be done, followed by the modified Schober's and occiput to wall distance. Ensure you are familiar with both of these. If there was any indication of cauda equina symptoms, you may offer to neurologically examine the legs and suggest that you might perform a PR. But that's not the case here. A focused cardiorespiratory exam listening to breath and heart sounds and performing a search for a collapsing pulse and to look for apical fibrosis or aortic regurgitation would be expected. There may be reduced chest expansion just due to bony restriction. Eye inspection and looking at the patient's Achilles tendons would also be a good idea. Investigations would include bloods for inflammatory markers and HLA-B27, as there is a very strong association in ankylosing spondylitis. Simple x-rays of the pelvis and the spine looking for sacroiliitis or new bone growth or syndesmophytes would be common, and fusion of the spine in advanced cases may occur. If x-rays are normal, an MRI spine may show early signs of inflammation. The breathlessness needs to be investigated with an FBC for anemia, baseline saturations, chest x-ray, ECG and an echocardiogram. Full lung function tests including spirometry and transfer factor may differentiate between mechanical restriction from pulmonary fibrosis as discussed in the case questioning, and a high-resolution CT thorax would be indicated. Pharmacological treatments have already been mentioned, such as non-steroidals and simple analgesics, but escalation to disease-modifying drugs such as sulfasalazine and anti-TNF drugs can be used. The need for pre-screening for latent TB was also discussed. Non-pharmacological treatments are important to consider, including physiotherapy. This is a case of ankylosing spondylitis, and the disease activity score, known as the Bath Ankylosing Spondylitis Disease Activity Index, or the BAS-DI score, can be used to assess disease activity. This is a 10-point scale, and anything above 4 indicates active disease.
Hello there.
Hi.
Is it Miss Platt?
Yeah.
My name's Gavin Britton. I'm one of the medical doctors in clinic today.
Okay.
I've been asked to have a discussion with you about abdominal pain. Would that be alright?
Yeah, that's fine, yeah.
Can you tell me a bit more about this abdominal pain?
So when I'm eating, I keep having to rush to the toilet because I'm getting really bad cramping in my stomach.
Okay.
And then it's making me really tired. I'm sleeping a lot.
So, and when did this start?
About a few months ago, really.
Okay. So it's been going on for a few months. And,
yeah.
Is it worse more recently, or?
Yeah, definitely. And it's as soon as I've ate as well. And I'm really struggling with certain foods.
Okay. And which foods is it?
Like pastas and like breads and stuff like that, and dairy products as well, milk.
Okay. Fine. And have you noticed any other changes?
I've got a diagnosis of arthritis already, but I've noticed that that's getting worse as well.
Okay.
Yeah.
And in what way is that getting worse?
My back pain, and it's just making me really tired because I'm in so much pain.
Okay. And are any of your other joints affected?
My wrists as well, but no, not apart from that.
And are your wrists flaring up currently as well?
Yeah, I think so.
Okay, fine. Is there anything else you've noticed currently?
No, not really. I get undigested food when I'm going to the toilet and I'm losing a lot of blood.
Okay. So when you open your bowels, is that loose or formed still?
Most of the time it's loose, but I'm noticing sometimes I can go for weeks without going to the toilet as well. It's just changing all the time.
Okay. And currently is it loose or?
Yeah.
And approximately how many times a day are you having to go to the toilet?
Oh, probably about 8 times a day, but I can be on the toilet for hours.
And is the blood mixed in with every motion, or is it more on the paper or in the palm?
No, it's mixed in.
Mixed in?
Yeah.
Is there any mucus in the stool?
Yeah.
Okay, fine. You mentioned that there's some undigested food. Is that within the stool or is that vomiting?
It's within the stool.
Within the stool.
Mm-hmm.
Are you vomiting at all?
No. I do feel sick quite a lot, but I don't vomit.
Okay.
Mm-hmm.
Have you noticed if you've had any fevers or hot flushes?
I get a lot of hot flushes at night time.
Okay.
Yeah, and it tends to wake me up in the middle of the night.
Okay. And any changes to your weight recently?
I do think I've been losing a little bit of weight.
Do you know if have you weighed yourself?
I've lost a few kilograms.
A few kilograms over what sort of time period?
Over a few weeks. Yeah,
Okay,
about a
fine.
month.
Has there been any changes with your appetite?
My appetite just changes, so sometimes I tend to like binge eat quite a lot, and then other times I won't eat anything at all.
Okay. Any difficulty with swallowing?
No.
Or any problems in the mouth, such as ulcers or sores?
I have had ulcers in the past, but it's not been a big issue for me.
Not currently, okay.
No.
Any changes with your eyes, such as pain, grittiness or redness?
Well, I've had uveitis in the past.
Okay.
And my eyes tend to get really bloodshot, and I do get a lot of pain, especially when there's like bright lights, and if I go outside from being inside and it's really light.
And is that currently you're having those
Yeah,
problems?
yeah.
Okay, fine. So we've touched on a couple of things there, but in terms of the background to your condition, do you have a known diagnosis? Have you been given a diagnosis for all these problems?
No, not yet.
No. And have you tried any treatments in the past?
I've had methotrexate in the past,
Okay.
and I'm on azathioprine at the moment.
Okay. And that's to control the eye symptoms and the abdominal
And the-
symptoms?
Yeah, and the joint pain.
Okay, fine. Do you have any other medical problems?
I've got fibromyalgia as well, and I've got POTS, so it's postural orthostatic tachycardia syndrome.
Fine.
Yeah.
Okay.
And hypermobility syndrome.
And in terms of medications that you take, is there anything that you take every day?
I take gabapentin as well.
Okay.
Yeah.
Anything else?
Sertraline.
Okay.
Omeprazole for gastro reflux.
Okay.
Yeah.
Any others?
No, that's it.
Anything over the counter or any injections?
No.
No. Okay, fine. Do you have any allergies?
No.
No. Can I ask, do you smoke?
No.
Ever smoked?
No.
No. And do you drink alcohol?
Yeah, occasionally.
How much in a week roughly would you drink?
Not a lot. I notice that when I do drink alcohol, it makes my symptoms a lot worse.
Okay.
I'd say like a couple of glasses of wine at the weekend.
Fine. Okay. And do you work currently?
Yeah.
What?
I'm an assistant psychologist, so yeah.
Has this affected your work at all?
Yeah, because I'm having to leave work a lot to go to the toilet, and I'm spending a lot of time on the toilet during the day, so
Okay.
yeah.
Is there anything that runs in the family?
My auntie has bowel problems, but there's no diagnosis.
Okay.
Yeah.
Any joint problems or eye problems in the family?
Just fibromyalgia.
Okay, fine. What I'd like to do now, if it's okay with you, is have a look at your abdomen. So if I can ask you to just step round onto the couch.
Yeah, that's fine.
Could I have a look at your hands? Do you have any pain in your hands or wrists?
Yeah, a little bit here and in between my knuckles.
I'll just have a quick feel if that's okay. Do you let me know if it's sore?
Okay.
Is that sore?
A little bit, yeah.
Okay, and
Yeah.
then the other side.
That's okay.
If I squeeze across here, is it sore at all?
A little bit. Yeah.
There. Anywhere else?
Yeah, there. That's okay.
Okay, and then this side.
A little bit.
And what about here?
No, that's fine.
There, okay.
They're okay, yeah.
And then on this side, is that okay?
Yeah.
Any pain there?
That last one's a bit sore.
Okay, and there?
That's alright.
Okay.
That's a bit tender there.
That's a bit sore.
Yeah,
And that one?
that's okay.
If I ask you to turn your hands over, and if you stretch your fingers right back, that's it. And then if you turn this hand back over, I'll just have a look at this finger. Okay. And put your wrists up like that. And you can relax that hand down. I'll just have a feel of this wrist. Can you peel one eyelid down for me? Okay, and relax. And open your mouth. Tongue up to the roof of your mouth. Okay. And if you sit forward for me, I'll have a feel of your neck. and then the other side. Okay, I'm just going to lie the bed flat.
Okay.
And if I could have a look at your abdomen.
Yeah.
Do you have any pain at the minute?
Yeah, it's in the middle and over the left side.
Would you mind if I have a feel of your
No, that's
abdomen?
fine.
Please do let me know if it's uncomfortable.
Yeah, it's quite tender there.
Okay.
And there. Yeah.
Okay. I'm just going to have a feel a little bit deeper, but do let me know if it's uncomfortable. Okay. If you can take a few breaths in and out. And again, breathe in and out. Okay. You're able to roll towards me.
Mhm.
Just breathe in and out. And again. And roll back. Thank you. I'll have a feel around this side. And on this side. Okay. That's okay. I'm just going to tap over your tummy now.
Okay.
And if you can roll towards me. It's okay, and roll back. Have a listen. Okay. Have you had any rashes on your body or legs?
No, not that I've noticed.
I'll just have a look at your legs.
Okay.
Is there any pain in your feet?
They're just a bit achy.
Any pain here?
No.
Or here?
A little bit tender.
Here?
No, that's okay.
Or here?
No, that's alright.
Okay. I can just ask you to sit forward and I'll have a look at your back. I'm going to have a feel down the spine if that's okay.
Yeah,
Are you in
that's
any
fine.
discomfort at the minute?
Just at the lower part of my back.
Do let me know if this is uncomfortable.
Okay.
Is that okay?
Yeah, just that lower one here.
Okay. Let's have another feel at the bottom. Is that sore at all?
Yeah.
Okay. And if you want to pop your t-shirt back on,
Yeah.
I'll just stand it for you.
Okay.
Okay, if I could ask you to do a few movements with your head. If you can put your head up towards the ceiling, down towards your chest, put your ear onto one shoulder, and then on the other shoulder. Turn your head to one side, and then the other side. Okay, and then just come back to the middle, and then with one hand run it down the side of your leg, as far as you can go. And then the other side. Okay, and if you can bend forward and try and touch your toes. Yep. And stand back up and stretch backwards as far as you can go. Okay, and then have a seat back on the bed. To complete my examination, I'd like to examine the hernial orifices, perform a digital rectal examination and urinalysis, as well as get a baseline set of observations. Thank you for letting me examine you today, Miss Platt. Is there anything that you're overly concerned about?
I'm just really worried about these bowel symptoms because obviously they've been getting worse over the past like 10 days and I'm in a lot of pain and I'm spending a lot of time on the toilet as well.
Okay. What I'd like to do, if it's okay with you, is perform some further investigations.
Okay.
I'm thinking that the background symptoms you've had with the eye discomfort and the uveitis that you've described, along with the joint pains that you had, might well be related to the symptoms you're having in your abdomen at the minute.
Right.
There is a condition called inflammatory bowel disease that is linked with these symptoms, and more specifically, because of those other symptoms you've had, including the mouth ulcers, there could well be a condition called Crohn's disease that you have, and I'd like to perform some more investigations for that disorder. Initially, however, I feel that your abdominal symptoms currently are troublesome enough to need to admit you to hospital, and I'd like to manage those symptoms in the first instance before we look into the background inflammatory bowel disease, if that's okay.
Okay.
So what I'd like to do, with your permission, is admit you to hospital, give you some pain relief and intravenous fluids, perform some blood tests and an x-ray of your abdomen, give you some intravenous steroids and potentially think about giving you some intravenous antibiotics as well.
Okay.
After that, we may well need a camera test looking at the colon and the large bowel to assess for the extent of inflammation, and then we can take things from there.
Okay, thank you.
Do you have any more questions or concerns?
No, that's it, thank you.
Thank you very much.
Thanks.
Please can you summarise this case for me?
This young female presents with a subacute history of abdominal symptoms spanning over the last few months, most notably with abdominal cramping, bloody diarrhoea and the passage of undigested food. She, importantly, is currently passing stool approximately 8 times per day and feels rather unwell. This is on the background of extra gastrointestinal symptoms of arthritis and previous uveitis, and I believe she has previously had mouth ulcers. I feel the underlying diagnosis here is one of inflammatory bowel disease, and because of these extra gastrointestinal symptoms, I suspect the diagnosis may well be Crohn's disease with a current exacerbation of her condition.
And how would you manage her from here?
After admitting this patient, I would want a full set of baseline observations, particularly looking at her blood pressure and heart rate and fever, looking for any signs of sepsis. I would then want to send off a stool sample for fecal calprotectin and a stool culture, looking for any evidence of infection, and order some baseline blood tests, including full blood count, looking for signs of anemia, and this could be microcytic anemia due to the blood loss, a normocytic anemia due to anemia of chronic disease, or a macrocytic anemia due to malabsorption. I would also be in particular looking at the neutrophil count and white cell count in conjunction with inflammatory markers for any signs of infection. I'd want baseline urea and electrolytes, looking for evidence of dehydration and the need for any electrolyte replacement, and I'd also want baseline liver function tests. I would want to request a baseline abdominal x-ray, looking for any evidence of dilatation. After these investigations, I would like to start the patient on appropriate painkillers, provide her with intravenous hydrocortisone to manage the acute exacerbation, and I may well consider intravenous antibiotics dependent on the baseline investigations. I'd also want to start intravenous fluid replacement and consider electrolyte replacement as appropriate. Additionally, I would start this patient on low molecular weight heparin due to the increased risk of venous thromboembolism.
Complications can sometimes occur due to a flare-up of Crohn's that needs surgical intervention. Are you aware of any indications for surgical intervention?
So I'd consider a surgical referral for patients with any evidence of dilatation on the abdominal x-ray, any evidence of fistulating disease, and also patients that are refractory to full medical management.
And if she doesn't need any surgical intervention and her condition gets better with the intravenous steroids and the treatment that you've initiated, and she is well and ready to go home, how would she be managed on discharge?
So I'd want to ensure she's on a long-term tapering course of steroids with appropriate replacement of vitamin D and calcium. And due to her previous use of immune modulating medications in azathioprine and methotrexate, I would want to refer her to a gastroenterologist to consider escalation of her treatment, and such agents that are used in inflammatory bowel disease are anti-TNF agents, and she may well be an appropriate patient for one of these. Additionally, I'd like this patient to be seen by an inflammatory bowel disease nurse and also have a dietitian review.
Would you consider any further investigations?
So I may refer her for a flexible sigmoidoscopy.
And do you know any differences between the endoscopic appearances in Crohn's disease and ulcerative colitis?
So in Crohn's disease, I would expect aphthous ulcers, cobblestoning and skip lesions, and transmural inflammation. There may also be isolated involvement of the terminal ileum, and I would also expect a normal rectum in Crohn's disease. Ulcerative colitis may demonstrate more superficial inflammation, which is restricted to the mucosa or submucosa. And there may well be evidence of crypt abscesses in ulcerative colitis.
Are there any concerns regarding malignancy in inflammatory bowel disease?
So there are concerns about malignancy, and these are specifically in patients with ulcerative colitis and Crohn's colitis. After 10 years of onset of symptoms, patients are recommended to have an index surveillance colonoscopy looking for signs of malignancy with appropriate biopsies. Further colonoscopic investigations are then carried out dependent on the patient's risk level at that stage.
Thank you.
Thank you.
There are two major forms of inflammatory bowel disease, Crohn's disease and ulcerative colitis. There is an overlap between the two conditions with similar clinical and to some extent histological features. But Crohn's colitis can affect any part of the gastrointestinal tract, whilst ulcerative colitis affects only the large bowel. Crohn's may involve one small area or multiple areas with relatively normal bowel in between, although it has a tendency to affect the terminal ileum. Skin rashes such as pyoderma gangrenosum or erythema nodosum should be asked for in the history and looked for in the examination. It is worth noting that smokers are twice as likely to develop Crohn's as non-smokers, so smoking cessation is very important. Endoscopic examination of the affected bowel can reveal deep ulcers and fissures in the mucosa, producing a cobblestone appearance. Fistulas or abscesses may occur. Microscopic examination reveals inflammation extending through all the layers of the bowel. Compare this to ulcerative colitis, where a superficial inflammation is instead seen. Acute attacks require steroids and appropriate supportive treatment such as IV fluids. Those with rectal involvement can be given rectal steroids. Steroid-induced remission can be maintained with immunosuppressant agents such as azathioprine, methotrexate or cyclosporin, and more recently anti-TNF treatment is now an option for refractory Crohn's. Unfortunately, up to 80% of patients with Crohn's will require an operation at some point during the course of their illness. However, surgery should be avoided if at all possible. If surgery is performed, minimal resections are undertaken due to a recurrence rate of up to 15% per year. Indications to consider surgery are failure of medical therapy, complications such as toxic dilatation, obstruction, perforation, abscesses or fistula formation. Due to the transmural inflammation in Crohn's, there is a higher incidence of these complications compared to ulcerative colitis. In ulcerative colitis, the inflammatory disease process is confined to the colon, and therefore colectomy is curative. The incidence of malignancy in both Crohn's and ulcerative colitis is increased, but only marginally so in Crohn's. Those that have had inflammatory bowel disease for more than 10 years will need regular lower GI endoscopies, performed for surveillance for colonic malignancy to try and detect early pre-malignant changes.
Hello there.
Hi.
Is it Louise Potter?
It is, yeah, but you can call me Louise.
Thank you. My name's Gavin Britton. I'm one of the medical doctors in clinic today.
Hello.
Your GP's asked me to see you regarding tingling in your hands and fingers. Is that correct?
That's right, yeah.
Can I ask you to tell me a bit more about that?
Well, it started about 5 months ago. One morning I was actually sat on the loo and I had a stretch and I felt a crunch in my neck. And then when I got up to wash my hands, I got this massive, it felt like an electric shock zipping down my back, and it was absolutely excruciating. And I couldn't move for about a second or two. It felt longer, but it went off. So I, washed my hands, started getting ready for work again. And then after that, I started to notice pins and needles sort of tingling, going down into these 2 fingers and my thumb. And on this side of my hand, it was really, really itchy and I was scratching away. That then started to progress from just being in this sort of direction. It started at my elbow and it was going down. Then it went up to my mid-arm and it went down. And then there was a pain in my shoulder blade here and it was spreading all the way down again. Pins, needles, tingling, intensely itchy. And at one point, my arm started going limp, like I was worried I was having a stroke.
Okay. And has this affected your right arm at all, or is it just your left?
No, just the left.
Okay. And you mentioned that your arm feels a bit heavy.
Yes.
Have you noticed any loss of strength in your arm?
It's difficult to say, but I have noticed my fingers feeling a bit fat and clumsy feeling. They don't feel right.
Okay. And have you noticed any difficulty with dexterity, such as buttons or picking up paper or coins off the table?
Buttons, yes. Now you mention it. And also I've noticed when I'm trying to pick coins out of my purse, my hands go into cramp.
Okay, fine. Is there anything else that you've noticed?
I think my walking's getting worse a bit,
Okay.
to be honest with you. Because it feels like my legs are stuck in mud when I'm walking on flat level surfaces. I feel like I'm dragging along, and I also feel like I'm losing balance quite a lot of the time. That's why I end up getting a stick, because I'm worried that I'm going to fall. And also I've noticed trying to get upstairs is really, really hard. It's like I don't have enough power in my legs to push myself up. It's a real struggle. There's times I've had to go up on my hands and knees almost. And also going up hills. I mean, I work as a home help, so I've just started the job. I thought I'd be getting fitter, but I can't even walk up the hill to the office.
When did the mobility problems start?
Oh, that was a little bit later, I think. Probably about 2-3 months ago.
Okay. And you've had to get the stick in that sort of time frame?
Yeah, because I did actually end up falling, and I don't feel safe. And as I say, if I turn around too quickly, I lose balance.
Okay. Have you injured yourself when you've fallen?
Well, when I've fallen, it's just like put my hands out like that, or falling flat on my back on my butt sort of thing, but nothing serious. Just
okay, fine. But your ability to walk around has reduced.
It's definitely, it doesn't feel right, but I can't explain why.
Okay, fine. Can I ask specifically, have you got any pain in the back?
The only pain I tend to get is actually in this shoulder blade here. Okay.
And is there any problems with your bladder or bowels?
No, not that I've noticed.
So they're okay, so not going to the toilet more often or needing to rush to get to the toilet?
No, not at the minute.
And no episodes of incontinence?
No.
Good, fine. Just to ask you a bit more about your background, if I can. Is there any other medical problems that you have?
No.
Do you see a doctor or a nurse frequently for anything?
Only for the routine, usual smear testing and getting a flu jab every year as well.
Fine. Do you take any medications?
Well, I take some paracetamol and ibuprofen for this. It seems to help, but then again, it doesn't always.
And do you have any allergies to anything?
I've got hay fever, but no other allergies.
And can I ask, is there anything that runs in the family?
Not that I'm aware of, but I'm adopted, so I don't know.
Fine. But in terms of mobility problems or problems with the legs or arms?
No, nothing apart from normal aging. We'll put it that way. Okay,
fine. You mentioned you work as a home help.
Home help, yeah.
Can I ask, do you drive for a living?
I drive between clients, obviously, and I also do the mum taxi type of thing. But that's about it, really.
Okay. Do you smoke?
No.
Have you ever smoked?
No.
And do you drink alcohol?
Yeah, I'm going to have to admit to that one, aren't I? But yes, I get a bottle of wine every month or so and enjoy it over the weekend.
Fine. So just some more specific questions now, if I can. Have you ever noticed any problems in the past, say, or many years ago potentially, with your eyesight?
No, apart from just needing glasses for reading, because I'm actually long-sighted.
Okay.
No.
Ever had any problems with speech or swallowing?
No.
And any problems with weakness in the legs or arms previously?
No.
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 No episodes of back pain in the past?
Well, I used to be a nurse, so yeah, obviously when you've been lifting patients, yeah, obviously a bit of stress and strain there, but nothing major.
Any accidents or trauma to the back?
No.
No. Okay. What I'd like to do now is do an examination of your legs and arms, and I'll start with having a look at your walking, if that's okay.
Yeah, sure.
For a short walk to the wall and back, would you need the stick?
No, I think I can manage that.
Okay. So if we can have a look at your walking then.
Okay.
And come back to. And just stop in front of the bed.
Okay.
And face this wall.
Right.
What I'm going to do now is ask you to close your eyes in a second.
Okay.
I'm here to catch you if you do fall. So when you're ready, close your eyes. Okay. That's okay. Are you okay? You can open your eyes.
Thank you.
So what we'd like to do now, if we can take your shoes off and slip back onto the bed.
Okay.
Are you able to roll your trousers up?
Yeah, sure. There you go.
Thank you. And pop your arms out. And you can rest your arms down.
Thank you.
Let your legs go all loose and floppy. I'm just going to move them from side to side.
Okay.
Are you in any discomfort currently?
No.
Please let me know if it's at all uncomfortable and we can
Okay,
stop.
will do.
Okay. If you can lift this leg up for me. And just a test of strength. So don't let me push you down. That's it. And the other side. That's it. And then if you can push down on this side.
Yeah.
Okay. And push down on the other side. Okay. If you can bend your leg at the knee. And push away. That's it. And pull towards you. Okay. And the other side. Push away. That's it. And pull towards you. That's it. If you can push down like on a car pedal. And push down on a car pedal. And then back up the other way. Back up the other way. Okay. And big toe up towards your head. Okay. And big toe up towards your head. Okay. Just check your reflexes.
Okay.
Just let your legs go all loose and floppy again. That's it. Okay. On the other side. Okay. And relax. And tickle the bottom of your foot. What I'm going to do now is check the feeling in your legs.
Okay.
I'm going to start by using this pin. It doesn't break the skin. I'll show you what it feels like in the middle.
Okay.
Can you feel that sharp?
Yes.
Can you feel it here
Yes.
and here?
Yes.
Does it feel the same on both sides?
Yes.
Does it feel the same as in the middle?
Yes.
Okay. You feel this?
Yes.
And here?
Yes.
Here?
Yes. It's sharper on that side.
So sharper on the left
Yeah.
compared to the right. And what about compared to the middle?
Sharper than there.
So sharper on the left. Here?
Yeah.
And here?
Yeah, it's still sharper.
Here? And here?
Yeah, still sharper on that side.
I'll do the same thing but with some cotton wool.
Yeah.
So I'll show you what it feels like in the middle. Can you feel that?
Yes.
Can you feel this?
Yes. Yes.
Does it feel the same on both sides?
It does.
Here?
Yes.
Here?
Yeah. Yeah.
Okay.
Yeah.
Next one I'll check is this vibrating feeling. I'll show you what it feels like in the middle. You feel that? Okay. I'd like you to close your eyes. Can you feel that?
Yes.
Tell me when it stops. you feel that?
Mhm.
Tell me when it stops.
No.
Okay. Lastly, if you can, with your heel, if you can put it onto this knee and slide it down your leg towards your ankle, lift it off and put it back to your knee and slide it down again. And do the other side for me. Great, okay, relax. I'm going to ask you to put your arms out.
Okay.
And if you turn your hands over and close your eyes. Okay, and open your eyes. With this finger, if you touch your nose and touch my finger. And again. Okay, and if you swap to the left side. And again. Thank you. What I'd like to do now is test your strength in your arms. If you put your arms up for me. Don't let me push you down. Don't let me push you down. Push me down. Push me down. Put your arms out like a boxer. Straighten your arm for me. And straighten this arm. Pull the arm in. Pull the arm in. Okay. Put your arms out and cock your wrists back. Don't let me push your hand down. Don't let me push your hand down. Okay. Spread your fingers out and keep them together. Don't let me push you down. Don't let me push you down. Spread your fingers right out. So push out against my finger. Okay. On this side. This one. And there. Okay. Turn your hands over. Put your thumbs up to the ceiling and reach your thumb towards your little finger. Don't let me stop you. Thumb towards your little finger. That's it. That's okay. I'll check your reflexes now. Let your arms go all loose and floppy. Okay, I'll borrow the other side. Okay. I'll borrow this side. Okay. I'll just have a look at your hands. Okay, that's okay. We'll check the feeling in your arms again.
Okay.
So this is a pin. I'll show you what it feels like in the middle again.
Yeah.
And if you turn your hands over, can you feel this?
Yeah.
And this?
Yes.
Does it feel the same on both sides?
It does.
And does it feel the same as in the middle?
Yes.
Okay, good. Can you feel here and here?
Yes.
Here and here?
Yes. Yeah. Yeah.
There and there?
Yeah.
And it feels the same on both sides?
It does, yeah.
Good. We'll just check the feeling in the middle again with this cotton wool.
Mhm.
And if you turn your hands over, you feel this and this?
Yes.
Here and here?
Yeah.
Here and here?
Yeah.
There and there?
Yeah.
There and there?
Yeah.
There and there?
Yeah.
Feels the same on both sides?
does, yeah.
Does it feel the same as in the middle?
Yes.
Good. So we'll check with this vibration again. Can you feel this?
Mhm.
And if you can have a look at your hands. If you can close your eyes, can you feel that?
Mhm.
Tell me when it stops.
No.
Okay. On this side, can you feel that?
Mhm.
Tell me when it stops.
No.
Okay, very good. That's okay, you can rest your hands down. I'll have a look at your face now if that's okay.
Yeah, sure.
If you can slip your glasses off for me. And I'll have a look in your eyes. Okay. I'll have a look in the back of your eyes.
Fundoscopy is normal.
Okay. And I'll have a look at the movement in your eyes now. If you could let me know if you get any double vision, but keep your head where it is and follow my finger with your eyes. Okay. If you can lift your eyebrows up, screw your eyes up really tight. Don't let me open your eyes. And the other side, don't let me open your eyes. That's it. You can pop your glasses back on.
Right, thank you.
And if you can smile for me, that's okay. Thank you.
Okay.
And just relax. So just to check, have there been any problems with weight loss?
No.
Or night sweats?
No.
Or fevers?
No.
Okay. So that's everything that I'd like to find out from you today.
Okay, thank you.
Is there anything that you're concerned about?
Well, I just want to get to the bottom of the pain and also try find out why my walking's gone so bad.
Okay. So what I'd like to do next is take some blood tests from you today and request an urgent MRI scan of your upper spine.
Okay.
The reason for this is I'm slightly concerned there may be a problem in the upper part of your spine that's caused the weakness in your lower legs and the problems with your hands and the numbness and pins and needles.
Okay.
Okay?
Okay.
To complete my examination, I'd like to check perianal sensation, do a digital rectal examination, and check for any evidence of a palpable bladder.
Can you summarise the history in this case?
This middle-aged lady presented with a 5-month history of radicular pain in the left arm, as well as features consistent with the Lamitis phenomenon. This then progressed to cause a deterioration in her mobility, resulting in falls and the dependence of a mobility aid.
What were your examination findings?
So this lady had features consistent with an asymmetric spastic paraparesis when I examined her. There was an ataxic gait and a positive Romberg's, but importantly, there were no cerebellar features. On closer examination of the lower limbs, tone was increased on both sides, but worse on the right than the left, with clonus on the right-hand side. Plantars were equivocal. Power was reduced in a pyramidal distribution, and upper limbs demonstrated atrophy of the small muscles of the hands, and there was weakness of abduction of the fingers. Reflexes were brisk globally, and there was a positive Hoffman's. Putting all this together, I feel this lady has a myelopathy, and this can be localised to either the cervical or upper thoracic region.
Did you find any cranial nerve abnormalities?
Cranial nerves were normal in this patient.
What features of the history are particularly helpful in trying to determine the etiology of a patient's myelopathy?
When thinking about the history, I'd want to consider any episodes of trauma as a cause of a mechanical cause for the myelopathy. A slower, more insidious onset of the symptoms may make me think of a degenerative process. Sudden, rapid onset of symptoms might make me think of a vascular cause to the myelopathy. And episodes in the history that might be consistent with previous episodes of neurological dysfunction may make me think of a relapsing remitting disorder. On systemic questioning of the patient, I'd want to screen for any possible malignant or autoimmune conditions that may be at play here. Lastly, I'd want to consider the family history of this patient, as it may be appropriate to think of familial conditions like hereditary spastic paraparesis.
Can you think of any other causes of myelopathy?
So other important things, I guess, to consider would be whether this patient had any symptoms consistent with malabsorption, or trying to tease out any symptoms of nutritional deficiencies, as these may be important differentials to consider as a cause of her myelopathy.
How would you localise the level of the myelopathy?
In patients with a myelopathy, I'd want to try and appreciate a sensory level, and then I'd go on to expect to find upper motor neuron features below the level of the lesion, and potentially lower motor neuron features at the level of the lesion.
How would you investigate this lady?
So initially, I'd want to request a baseline blood tests, including a full blood count and an ESR, looking for any sign of inflammation. And if this is present, I may wish to go on to consider screening in a broader sense for autoimmune conditions. However, as part of my baseline screening, I'd want to also do baseline urea and electrolytes and liver function tests, as well as a baseline B12, and I may wish to consider copper studies here as well, looking for evidence of those nutritional deficiencies. Importantly, I'd want to request an urgent MRI scan, and I'd localise this to the cervical and thoracic region.
If the MR spine did show degenerative cervical myelopathy, how would you manage her?
So the most important step in the management here would be onward referral to the neurosurgical team, and dependent on the features of the MRI scan, such as evidence of cord impingement or cord compromise, would determine the urgency of this referral. I'd also obviously want to make sure the patient has appropriate analgesia.
Does physiotherapy have a role here?
Physiotherapy does have a role here, and dependent on the cause of the myelopathy would change when the physiotherapy would be indicated. In an unstable cervical cord, for example, you wouldn't want to start physiotherapy until after the underlying cause, such as a neurosurgical intervention, has been performed. However, in the long term, onward referral to the neurorehabilitation multidisciplinary teams, including physiotherapists, would be important for this patient. Other important reviews would include occupational therapy input, as well as neurorehabilitation consultants who may wish to concentrate on other systems that may have been compromised here, such as bladder and bowel complications.
Thank you.
Thank you.
This lady presented with hand symptoms over a number of months and associated gait problems with falls. The candidate detected the slightly unsteady and broad-based gait, so wisely didn't attempt to do tandem gait. Romberg's test was checked, and in this case it was positive. The lower limb exam was performed well, it was fluent, professional, and all the important elements were covered. The candidate checked tone, power, reflexes, coordination, and sensory modalities. The increased tone, ankle clonus, brisk reflexes, and mild weakness all helped to define a spastic paraparesis. The findings were asymmetrical, and the upper motor neuron signs were more apparent on the right. The sensory findings were very subtle, and all that could be detected was a relative hyperesthesia in the left leg. This combination of pyramidal signs, prominent on one side, and spinothalamic dysfunction on the contralateral side, mean that this could reasonably be presented as a partial Brown-Séquard syndrome. These signs are highly suggestive of myelopathy, or in other words, spinal cord dysfunction. This is the clinical consultation lasting 15 minutes for the patient interaction, and hence there is time for a focused cranial nerve and upper limb examination as well to allow localization of the lesion. But you also want to look for signs of other neurological lesions that might hint at a multifocal disease process such as multiple sclerosis. So for instance, if this patient had evidence of a pale optic disc and relative afferent pupillary defects, one could say that the combination of an optic neuropathy and partial myelopathy would be highly suggestive of multiple sclerosis. One would also offer to look for evidence of a sensory level on the trunk. This is another one of those situations where it's only really possible to come up with a syndromic diagnosis and then offer a differential diagnosis for underlying causes. The candidate did an excellent job here and provided a highly structured approach to the differential diagnosis. The candidate was also able to explain how they would use key points in the history to narrow down the broad differential diagnosis. When you detect signs of a myelopathy, perhaps the most critical investigation is going to be an MRI scan of the spine, and your clinical localization from the full neurological exam will hopefully guide you precisely to which segment needs to be scanned. The urgency with which the scan is arranged is determined by how quickly the patient's symptoms have come on and the severity of the signs. In acute onset or rapidly progressive syndromes, the patient really should have a same-day MRI scan, as we are looking to exclude acute decompression that may need urgent surgery or metastatic disease that could require same-day radiotherapy. In many slowly progressing or static cases, the scan could be arranged as an outpatient.
Hi, is it Jack Stewart?
Yeah.
My name's Gavin Britton, I'm one of the medical doctors. Your GP sent you in and asked me to have a look at you because I believe you've had a headache and you've been feeling quite unwell. Is that right?
Yes, it is, yeah.
Can you tell me a bit more about what's been going on?
At the start of the week, I've just not been able to eat, just not being hungry, and then I've had a headache that's got constantly worse. And over the last couple of days, I've been feeling really sick with it, and I've been vomiting a few times.
Okay. So just to clarify, your appetite's been reduced.
Yeah.
You started with a headache and you've had some vomiting as well.
Yeah.
Okay. Is there anything else that you've noticed?
My neck's been a bit stiff.
Okay, fine. Can I ask you a bit more about the headache?
Yeah.
So when did that start?
Beginning of the week.
Okay, so about a week ago.
Yeah.
And did it start suddenly?
No, it was more like a gradual, constant headache over the week.
Okay. And where is the headache?
It's just Just all over.
Okay. Does it move anywhere?
No.
No. And does it spread down to the neck or spread anywhere else?
Well, yeah, because I'm getting like a stiff neck as well.
Okay, fine. Is there anything that makes the headache worse?
Light a little bit.
Okay.
Like when I get up and I look outside, it's just.
So bright lights seem to
Yeah.
make it worse. If I ask specifically about coughing or laughing or sneezing,
No.
or have you noticed it getting worse when you go to the toilet, for example?
No.
Or if you bend forward?
A little bit when I'm bending forward, yeah.
Okay. And what about lying flat?
No,
Any worse or
yeah.
better?
Not really.
Okay, fine. Is there anything that's made the headache better?
I've been trying to treat with paracetamol, but it's not really taking the edge off at all.
And have you tried any other medications?
No.
No, just the paracetamol. Fine. And is there anything else that has come along with the headache? You've mentioned about the nausea and the vomiting. Have you noticed anything else, such as a rash or a fever?
No, not really, no.
No. And no fever either?
No.
No, fine, good. Any night sweats?
Well, it's been warm, but, you know, that's usual, isn't it, with the
Okay.
weather?
Fine, okay. And is this headache there all the time, or does it seem to come and go?
It's just constant.
Fine.
Constant.
And if you could describe it, how would you?
It's like someone drilling in my head a little bit,
Okay,
but not at one point, it's just like all over.
sure. And with 10 being the worst possible pain and 0 being nothing, where would you put this on the scale?
10.
So a 10 out of 10.
Yeah.
Fine. Have you had headaches in the past?
Not really.
No. So
No.
you're not the type of person who normally gets headaches?
No.
No. Fine. Have you noticed any abnormalities with your vision?
Not really, no.
And prior to the onset of this headache, you didn't have any odd flashing lights or zigzag lines in your vision at all?
No.
No. Fine, okay. If I ask a bit more about your background now, if that's okay.
Yeah, yeah.
Do you have any other medical problems?
No.
And is there anything else you see a doctor or a nurse for?
No.
Fine. Do you take any medications currently?
Only paracetamol for the headaches.
And is there anything you take over the counter?
No.
No. And do you have any allergies?
No.
Fine. So just a bit more about home life. Who do you live with?
I live in halls.
So you're a university student?
Yeah.
Can I ask how old you are?
I'm 22.
Is there anybody else in halls or at home who is unwell currently?
Not that I know of, no.
Okay, fine. And in terms of university life, how are you finding that?
I'm enjoying it. I am enjoying it. Yeah.
Any undue stress currently or examinations coming up?
I've got deadlines coming up, but I'm ahead really, so
Fine, okay. And can I ask, do you smoke?
no.
Have you ever smoked?
No.
Do you drink alcohol?
Yes.
How much would you drink in a week?
6 to 10 units depending.
Okay, fine. And in terms of your family, is there anything that runs in the family?
No.
Anybody have headaches at all?
Oh, my mum moans about them sometimes, but nothing major.
Do you know if she's ever been given a diagnosis?
No.
Okay, fine. Just to go back to a couple more points, if I can. Have you noticed at any point over the last week a rash at all?
No.
Any problems with your joints or muscles? Aching?
No.
No, fine. We mentioned that your appetite was slightly reduced. Are you managing to get enough liquids and food in?
Yeah, I've tried to up my water intake just to, because I'm not eating a lot, it just makes sense to.
Obviously, you've mentioned the vomiting. Have you noticed any diarrhea at all?
No.
Okay. How is your bowel habit at the minute?
Fine, I'd say, yeah.
Okay, fine. And in terms of urinating, have you noticed any change in frequency or any burning or stinging when you urinate?
No.
And the frequency is the same as normal?
Yeah, I would
Good.
say so.
Good, fine. Have you or others noticed any abnormal movements in your arms or legs or any episodes of loss of consciousness?
No.
And have you noticed any arm or leg weakness? Or pins and needles in the arms or legs?
No.
Have you noticed a fever at all?
No.
And any symptoms that might fit with a cold, such as a runny nose or a stuffy nose?
No, no.
Any pain in the face?
Not really, no.
Or any pain or discharge from the ear?
No.
No, fine, that's okay. Have you noticed any ringing or what's called tinnitus in the ears?
No.
No, okay. Is there any substances that you might use that aren't prescribed or that you obtain from elsewhere?
No.
No. And have you recently travelled anywhere?
Went to Benidorm last week.
Okay. And were you unwell while you were in Benidorm?
No.
And can I ask, this is quite a sensitive question, but have you ever been tested, or would you consider yourself at risk of HIV?
No.
Fine. Okay. If it's okay with you, what I'd like to do next is have a look at the nerves in your head and face, and then we'll go on to have a look at the nerves in your arms and legs as well.
Okay.
So I'll start by having a look at your eyesight, if that's okay.
Cool.
What I'd like you to do is cover one eye, and if you can read from the top down.
T V H X U A H T Y O V U A X T H A Y O U X Y U X T H A O V.
Okay. Any further?
No.
Okay. On the other side.
T V H X U A H T Y O V U A X T H A Y O U X Y U X T H A O V.
Okay. And is that it?
Yeah.
Okay. Thank you. Just shine a light in your eyes. If you can look straight ahead for me. And if you can pick a point on the wall behind me, and then look at my finger. Look at my finger. Okay. I'll have a look in the back of your eyes now. So blink as much as you need to, but just stare straight ahead. Okay, on the other side. Okay. And if you can cover up one eye for me, and I'll cover the same one. And if you look straight into my eye and tell me when you can see this red dot.
Yeah. 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 Yeah.
Okay, and again.
Yeah. Yeah. Yeah.
And if you stay as you are and keep looking at me, say yes again.
Yeah. Yeah. Yeah.
And again.
Yeah. Yeah.
Okay.
Yeah.
And swap sides for me. And look at my eye again. Yeah.
Yeah. Yeah. Yeah.
Again.
Yeah. Yeah. Yeah.
Okay. And you stay as you are, I'll swap sides.
Yeah. 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 Yeah.
Brilliant. Okay. Next, if I can ask you to keep your head facing straight forward, but with your eyes follow my finger. Okay. Was that okay?
Yeah.
Okay. If you can clench your teeth for me, I'm just going to have a feel of your jaw. Okay, that's okay. And relax. This piece of cotton wool, can I show you what it feels like in the middle?
Okay.
If you just pull down your t-shirt, can you feel that?
Yeah.
Can you feel this on your face?
Yeah.
Does it feel the same on both sides?
Yeah.
And the same as in the middle?
Yeah.
Good, okay. If you can lift your eyebrows up for me. Close your eyes up really, really tight. Don't let me open your eyes. On the other side. That's okay. Open your eyes. Smile for me. That's okay. That's fine. I'll have a look in your ears. Have you noticed any problems with your hearing?
No.
And I'll come on the other side. That's okay. And if you can open your mouth for me and just say ah. That's fine. That's okay. What I'd like to do now is see you walking. So if I can just ask you to stand up and walk towards the wall for me. And if you can walk towards this wall, and stop when you get there. And just turn around. And I'm here to support you, but if you can walk back heel to toe as if you're on a tightrope. That's brilliant, and just stop there. If you can stand in front of the bed facing this wall, put your feet together, and when you're ready, close your eyes, and again I'm here to support you. That's great, thank you. If you could slip your shoes off and rest back onto the bed. Are you quite comfortable there?
Yeah, just my neck's a bit stiff.
Okay. Do let me know if anything's uncomfortable while we're having a look at your legs and arms. Okay. Could I ask you to put your hands out? Turn your hands over and close your eyes. Thank you. And open your eyes. With this finger, touch your nose, touch my finger, and go back again, and back to my finger, and do the other side for me. Okay. Just let your arms go all loose and floppy. I'm just going to take the weight of this arm. Okay. And then the other side. That's okay. With your arms, could you pop them up like this for me? I'm going to test the strength in your arms now. Don't let me push you down. Don't let me push you down. Push me down. Push me down. Put your arms out like a boxer. Push me away. Again, push me away. Pull me towards you. Pull me towards you. Put your hands out. Cock your wrists back. Don't let me push you down. Don't let me push you down. And then if you can grip onto my fingers, that's it, and don't let me take them out. That's it. Just relax your arms down. I'll just check your reflexes. To let them go all loose and floppy again. The other side. That's okay. If I can ask you to sit forward now, I'm just going to lie the bed flat. And if you want to rest back. Okay. Is that comfortable?
Yeah, it's just stiff, my neck.
Okay. Can I ask you to put your chin towards your chest? Is that quite sore?
Yeah.
Can I just have a quick look if you relax back for me? I'm just going to move your head. Is that quite sore?
Yeah.
Okay, fine. I'm going to move your legs from side to side now. Just try and let them go all loose and floppy. Okay. Do you have any pain in your back at all?
No.
I'm going to lift this leg up. Is that okay?
Neck.
Okay, I'll just relax that one back down. Have a look at the strength in your legs now. If you could lift this leg up towards the ceiling for me, don't let me push it down. That's it, and then the other side. That's it, and then down towards the bed. That's it, and this side down towards the bed. That's it. Could you bend your leg at the knee and kick out for me? That's it, and pull in towards your bottom. That's it, and you can straighten that leg out. And again, this one, if you bend your leg, kick out for me, pull in towards your bottom. That's it. Push down on a car pedal, and on this side, push down on the car pedal and lift up towards your head. That's it, lift up towards your head. That's it. Just check your reflexes now. Just let your legs go all loose and floppy. That's it. And on the other side. Okay. I'm just going to move your ankles. Okay. I'm just going to tickle the bottom of your foot with this stick. Okay. That's okay. I'll sit you back up now. Is there anything that you're particularly concerned about?
Just that it's something really serious.
Okay. The most concerning thing for me is that I'm worried that there could be inflammation in the brain caused by an infection. This is something that you may have heard about previously and is termed meningitis. What I'd like to do from here is admit you to hospital, perform some baseline observations and some basic blood tests, as well as administer some antibiotics and intravenous fluids. After that, we'll go on to perform imaging of the brain, and we may well need samples from the fluid that surrounds your brain and spinal cord. I realise that's quite a lot of information to take in. Do you have any specific questions?
Can you just let me know what the tests say?
Of course, I'll come back after the first round of tests are back. Thank you. That completes my examination.
Can you summarise your findings for me and talk me through this case?
This young man has presented with generalised malaise and a headache along with neck stiffness. The most important diagnosis I'd like to exclude, therefore, is that of bacterial meningitis. On examination, there were no focal neurological signs and fundoscopy was normal. However, there was evidence of neck stiffness and Koenig's sign was positive. Importantly, there were no features of encephalitis, and this patient was not immunocompromised.
Are there any other possible types of meningitis in addition to bacterial that this could be?
Other types of meningitis include viral meningitis, Lyme meningitis, fungal meningitis or meningitis caused by protozoa. And I'd also want to consider, in cases of meningitis, paraneoplastic or malignant causes of meningitis.
How would you manage a patient with acute suspected bacterial meningitis?
As with any acutely unwell patient, I'd approach with an ABCD manner. I'd want to take baseline blood tests with a full blood count and inflammatory markers, looking for signs of infection. I'd want baseline renal profile and liver function tests along with clotting studies. I'd also want a baseline glucose and lactate. I'd proceed to administering broad spectrum antibiotics without delay, according to local protocols and any allergies that the patient may have. I'd also administer intravenous fluids as appropriate and ensure I complete the remainder of the sepsis 6 bundle. Additionally, this patient may well require neuroimaging, potentially in the form of a CT of the brain, if there is any signs of reduced consciousness, any features of raised intracranial pressure or focal neurological features, or papilledema. Following this, I'd want to perform a lumbar puncture and I'd send samples for cell count and culture, viral studies, a protein and paired glucose, and a lactate.
How does the lumbar puncture findings differentiate a bacterial from a viral meningitis?
In bacterial meningitis, I'd expect to see a raised white cell count, and this would be predominantly neutrophils. I may expect to see a raised protein count in addition to this, but importantly, I'd expect the glucose to show a low CSF to serum glucose ratio. Additionally, I'd be looking out for a positive gram stain and the culture results. A viral meningitis may also show raised white cells, however I'd expect these to be predominantly lymphocytes. The protein count in these cases can be normal but can sometimes also be raised, but the CSF to serum glucose ratio should be normal. In the cases of viral meningitis, I'd be looking out for the results of the viral PCRs.
What are the potential complications of bacterial meningitis?
So meningitis can be fatal. However, severe morbidity can result from bacterial meningitis, and this can include permanent neurological sequelae such as deafness and blindness, as well as cognitive problems. Other important complications would be that of vascular complications, such as the requirement of amputations, and this is usually as a direct result of a sepsis syndrome.
If the initial investigations were normal, are there any other differential diagnoses to be considered here?
In this patient, I may well want to consider migraine as a other differential. Other reasonable differentials might well include a non-specific viral illness. However, this is a diagnosis of exclusion and isn't one I'd want to jump to, given the other important differentials.
Again, if the initial investigations were normal, such as the lumbar puncture, and you were considering migraine, how would you manage that?
So I'd want to split my management of migraine into acute treatment and prophylactic treatment. However, in this acute setting, I'd want to first off consider simple analgesia such as paracetamol and non-steroidal agents such as ibuprofen and naproxen. If early in the headache onset, I might want to consider triptans, and I may also want to consider an antiemetic, especially metoclopramide or domperidone if that's not available or not appropriate. Prophylactic treatment can be given to patients who have recurrent or debilitating migraine, and these agents should be selected dependent on patient features.
Thank you.
Thank you.
Patients presenting with headache for the first time, or with headache that differs significantly from their usual headache, should have a thorough, detailed history and clinical examination, and a focused neurological examination, fundoscopy, otoscopy, temperature and blood pressure. In this 15-minute clinical consultation, a systematic approach is essential, and following the history, a very detailed cranial nerve examination and more focused upper and lower limb examination is needed. If a patient presents with headache and a combination of all or some of the following signs or symptoms, such as fever, neck stiffness, focal signs or seizures, then infection of the central nervous system should be considered. Infection may be diffuse due to meningitis or encephalitis, or more localized due to a brain abscess. Heightened suspicion is appropriate if there is a history of HIV or immunosuppression. The differential diagnosis of headache is wide and includes very serious acute causes such as meningitis, subarachnoid hemorrhage, venous sinus thrombosis, or more sinister causes such as a space-occupying lesion, inflammatory causes such as giant cell arteritis, or more benign causes such as migraine. Key questions therefore to ask a patient presenting with a headache and try and identify the symptoms consistent with meningitis would include the presence of meningism, i.e. is there any neck stiffness, headache or photophobia? Do they have nausea and vomiting? Is there any focal neurological deficit? And are there any constitutional symptoms of infection? And very importantly, is there a rash? Risk factors associated with certain headaches, such as meningitis, include the patient being immunosuppressed, close contact with other people with meningitis, or foreign travel. Subarachnoid hemorrhage tends to be of sudden onset and sometimes described as a thunderclap headache, which may be preceded by warning sentinel headaches. Risk factors for subarachnoid hemorrhage include hypertension or a family history of subarachnoid hemorrhage. Symptoms of classical migraine type headaches can include the fact that the headache is pulsating and tends to be unilateral and associated with nausea. It is often disabling for the patient, and the onset is usually within 4 to 72 hours. There is often an aura, such as partial loss of vision or flashing lights, and focal neurological deficits may be observed in up to 30% of cases. Trigger factors for migraine can include certain foods, such as chocolate or red wine, and certain stresses or tiredness. Red flag symptoms or signs suggesting a secondary cause or a sinister cause for the headache include a headache occurring in a patient that's over 50 years old, inability to move a limb or abnormal neurological features, mental confusion, being awoken by a headache, and a headache that's worsening with changes in posture, exertion, coughing or sneezing would tend to be associated with raised intracranial pressure. Symptoms of giant cell arteritis include again a unilateral headache, unresponsiveness to standard analgesics, scalp tenderness to palpation, visual loss, jaw or lingular claudication, which is pain in the jaw or tongue on chewing, which resolves afterwards. Examination needs to be focused and should include the relevant specific areas of cranial nerves, then upper and lower limb neurological examination, but it is appreciated that this will be somewhat abbreviated depending upon time constraints. Signs of neck stiffness should be assessed by passive neck movement with the patient supine and should include Koenig sign in this position. Fundoscopy will give an appreciation of photophobia and raised intracranial pressure due to papilledema. Ear examination with an oroscope is essential. In general, whenever the diagnosis of meningitis is strongly considered, a lumbar puncture should be performed promptly to examine the cerebrospinal fluid. This is the cornerstone of the diagnosis. The diagnosis of bacterial meningitis is made by culture of the CSF sample. The opening pressure should be measured and the fluid sent for cell count and differential count, biochemistry, i.e. CSF, glucose and protein, and microbiology, gram stain and culture. In patients with suspicion of raised intracranial pressure, an urgent CT scan should be performed prior to performing a lumbar puncture. A concern regarding lumbar puncture is that the lowering of CSF pressure caused by the withdrawal of CSF could precipitate herniation of the brain through the foramen magnum. Herniation can sometimes occur in acute bacterial meningitis and other CNS infections as the consequence of severe cerebral edema or acute hydrocephalus. Clinically, this is manifest by an altered state of consciousness, abnormalities in pupil reflexes, and decerebrate or decorticate posturing. Ideally, the lumbar puncture should also be performed before starting antibiotics in order to allow the best chance of a definitive diagnosis, but should not be delayed and should be commenced at the time of bloods and blood culture being taken if the lumbar puncture is to be delayed. Those patients who present with a pattern of recurrent episodes of severe disabling headache associated with nausea and sensitivity to light, and who have a normal neurological exam, could be considered to have possible migraine, which has specific treatment options as discussed in the case.
Hello there, is it Mrs. Boss?
Yes, it is.
My name's Gavin Britton, I'm one of the medical doctors.
Hi.
Your GP's asked me to see you today regarding your tiredness and I believe some problems that you've encountered when you're sleeping at night. Is that correct?
Yeah, that's right.
Could you tell me a bit more about these problems?
I snore more and I stop breathing during the night. My husband said that. Just for a few, about 10, 20 seconds, something like that. When I wake up, I'm tired.
Okay.
Like I've not had much sleep.
Fine. So just to recap, your husband's commented that you're snoring quite a bit at night.
Yeah.
You're stopping breathing, you're pausing and breathing at times.
Yeah.
And sleep, you find in the morning that you're not refreshed from sleep.
No, I'm not.
When did these problems first start?
Probably a couple of, maybe a year or so ago.
Okay. And are you finding yourself sleepy during the day?
Yeah.
And do you ever drop off to sleep at all?
Yeah, they can be talking to me and next thing I'm falling asleep.
Okay. And is that quite frequent? Or?
In the afternoons, didn't used to be, but getting more.
Okay. Have you run into any difficulties with this?
If I need to be somewhere and I'm feeling tired, I don't drive.
Okay.
But other than that, just feeling tired all the time.
And have you ever fallen asleep, for example, when driving, say
No.
stopped at traffic lights, or
No.
when using machinery or anything like that?
No, I haven't.
Fine, okay. And is there anything else that you've noticed at all?
My hands have got bigger. They're swollen all the time and they're numb.
Okay.
My feet have got bigger as well.
And have you found that your shoe size has changed at all?
Yeah, it's gone from a 6 to a 9.
Okay, fine. So there's been some changes in your hands and feet then as well?
Yeah, they got wider in feet.
They've got wider, okay, fine. Can I ask, do you have any other medical problems?
I just get headaches
Okay,
and allergies.
okay. And are these headaches at any particular time of day?
No.
No, okay. And have you seen a doctor or a nurse for anything recently?
Just about my headaches.
Okay, fine. Do you take any medications
For the headaches,
for anything?
I've been prescribed amitriptyline for
Okay.
headaches. So, and just gabapentin for my nerve damage in my hands.
Okay. And has anybody said what the nerve damage in your hands is?
Bilateral carpal tunnel.
So you've got carpal tunnel on both
Yeah.
sides. Okay. And you take medications for that?
Gabapentin, yeah.
Just the gabapentin. Do you use any splints or have you had any surgery for that?
I use splints and I use the TENS machine. So
Okay, fine. Just a bit more about your home life, if I may. Can I ask, who do you live with?
my husband and my 2 children.
Okay. And do you work?
Yeah.
Okay. And what do you do?
Carer.
Okay. And have these problems affected your work at all?
Just being tired. Just kind of push myself to do my shifts, and I'm exhausted at the end of it.
Okay. You've not found yourself falling asleep at work?
No,
Okay.
I don't have time.
Okay. Do you smoke?
No.
Have you ever smoked?
No.
Do you drink alcohol at all?
At special occasions,
Okay.
so not regularly.
fine. You haven't noticed if alcohol makes any of these problems worse at all?
No.
No. Okay, fine. Are there any medical problems that run in the family?
Not hereditary ones, no.
Fine. Okay. Just coming back to some more specific questions, if I can. You mentioned some numbness in the fingers. Where is the numbness in the fingers?
The tips of my fingers, and I feel at different times of the day, depending on what I'm doing, the rest of my hand gets affected.
Okay. Have you noticed any problems with your eyesight at all?
It's getting worse. Reading wise, close-up work, I have to have the glasses changed quite regularly.
Okay.
So
you've over the last how long have you had to have your glasses changed?
about 5 years.
Okay.
Yeah.
Fine. Have you found yourself bumping into things, for example, or struggling with vehicles coming at you from the side?
I get a bit clumsy, but not really vehicles coming at
Okay.
me.
What do you mean by clumsy?
I could be rushing around and then bump into something.
Okay.
Yeah.
At the side, or
Yeah, or
okay.
I go to pick something up and my hands are just too numb and I drop it.
Okay.
So
Have you noticed any problems with feeling the need to drink lots of fluids during the day?
sometimes, yeah, the amitriptyline side effect of that is dry mouth. So,
Okay.
Yeah.
Fine. In terms of urinating, are you going to the toilet more often?
No.
No, it's just the same as normal?
Yeah.
Okay, fine. Can I ask, has there been any change in your weight?
Put on weight.
Okay, and do you know how much weight you've put on roughly?
No, quite a bit though.
Okay, fine. Has there been any change in your appetite?
I get hungry every couple of hours, so I have to have something, even if it's something small.
Okay, fine. Have there been any changes with your ability to tolerate hot or cold environments?
I've always not liked the cold.
Okay.
I feel cold quite quickly.
Okay.
So,
And have you had any problems with palpitations?
yeah, I've had that, yeah.
Okay, fine. And
That happens a lot at night. as well.
you have,
Yeah.
you feel your
heart,
palpitations?
yeah.
Okay, fine. And lastly, have you noticed any change in your bowel habit?
No.
So that's
the
it.
same, yeah.
Okay, fine. What I'd like to do now, if it's okay with you, is have a look at things in a bit more detail and examine your face and a couple of other things, if that's okay.
Yeah.
Okay. I'll start by having a look at your eyesight.
Okay.
Could I ask you to cover one eye and then read from the top down?
TVHXUA HTYO VUAXT HAYOUX. So just carry on.
If you can.
Yeah. YUXTHAOV XOATVHUW.
Brilliant.
UY,
Okay.
sorry.
And the other side for me?
TVHXUA HTYO VUAXT HAYOUX YUXTHAOV XOAVHUY.
Okay, thank you. If you could slip your glasses off for me, I'll just shine a light in your eyes. If you look at the point on the wall behind me. Okay. And then if you look at the wall behind me, and then look at my finger. That's okay. I'm just going to have a look in the backs of your eyes now. If you just look straight ahead and blink as much as you need to. Okay, and I'll come around the other side. Okay. You can put your glasses back on. And if you can cover one eye for me, and I'll cover the same one. I want you to look into my eye and say yes when you can see the red pin.
Yes. 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 Yes.
Okay, I'm going to swap sides, you stay as you are.
Yes. Yeah. Yeah. No. Yeah. Yeah.
Okay. And if you swap sides to me.
Yeah. 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 Yeah.
Okay, now swap sides.
Yeah. 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 Yeah.
Okay, very good. So if you can keep looking with your head looking straight forward, but with your eyes follow my finger. Do let me know if you get any double vision. Okay, fine, that's okay. Have a look at your hands now if that's okay.
Yeah.
Pop them on this pillow. And turn them over. Please put your hands like this. And we'll just keep them there for 30 seconds. And relax. How's the feeling in your hands?
Tingling down there.
Okay,
Yeah.
fine. I'm just going to move this pillow. I'm going to come round the back and have a feel of your neck now, if that's all right. Do you have any discomfort or pain in the front of your neck?
Not in the front, no.
I'm going to have a feel of your neck, if that's okay. Just going to have a feel of the front of your neck now. Can you swallow for me? Okay, and on the other side. Again, if you swallow for me. Okay, thank you. Have you noticed any difficulties walking upstairs?
No.
Or reaching for items on high shelves?
No.
Okay. Could I ask you to cross your arms like this and stand up for me? Great. And just relax for me. And when you're ready, make your way around to the bed. And just slip your shoes and socks off and make yourself comfortable. Okay, and just rest back. That's okay. Thank you. Can you put your hands out? Thank you. And you can rest that one down. I'll borrow this wrist. Thank you. Can I ask, have you noticed any breathlessness at rest or on exercise?
No.
Okay. I'll have a look at your feet now, if that's okay.
Yeah.
Is there any pain in your ankles?
No.
I'm just going to press on them. Can I ask, is there anything that's worrying you?
Just not being able to sleep properly and being tired all the time. The snoring.
Okay. So, based on what you've told me during the history, I think you may well have a condition called obstructive sleep apnea. I'd like to perform more tests for that, and that would involve doing some testing overnight to confirm this, and after that we can discuss potential treatments to help with the tiredness that you're experiencing during the day, and I'd hope we can help things substantially actually. However, taken in association with the other symptoms you've told me about, so with the change in facial appearance, the change in hand and feet size, as well as potentially with the headaches and the history of carpal tunnel on both sides, it may be that there's an underlying reason for all of these things. that could be a condition called acromegaly. This is probably something that you've not heard about before, but is a condition that causes soft tissue swelling, essentially, but also swelling of the joints and bones. What I'd like to do is investigate for that condition as well, and today I'd like to perform some blood tests. Thereafter, we might want to do some imaging of the brain in a form of an MRI scan, and we'll talk about the results as they come back.
Right, okay.
Do you have any more questions?
Is there a cure for it? Or?
So in terms of the obstructive sleep apnea, there's quite a few treatments that we can try once we've confirmed the diagnosis. And again, in terms of the acromegaly, once we've confirmed the diagnosis, we can discuss things further, but treatments would involve a referral to an endocrinologist, and they potentially, based on the findings that they see when we do the imaging, may want to consider doing surgery, as acromegaly is caused by a small growth that can occur within the brain that can cause these features that you've told me about.
Okay.
To complete my examination, I'd like to request this patient's blood pressure and perform urinalysis.
Thank you.
Thank you.
Having taken the history and examined this lady today, can you tell me your findings?
This lady presents with a history of lethargy and daytime somnolence, with features in the history consistent with sleep apnea. These are seen in the context of an increase in hand and feet size. On examination, there was clear swelling in the hands, feet and face. There was splaying of the teeth and a clear overbite of the jaw. Phelan's test was positive bilaterally, and this would be in keeping with a bilateral carpal tunnel syndrome. Important negatives, including an absence of any proximal myopathy, as well as fundoscopy, visual fields and visual acuity, all being normal. Whilst there were features in the history consistent with thyroid disease, the pulse was 74 beats per minute and regular. There were no clear masses around the thyroid region, and I did not clearly demonstrate any other features of thyroid disease. In conclusion, I think this lady has acromegaly in association with bilateral carpal tunnel syndrome and obstructive sleep apnea.
What investigations would you perform?
I'd want a baseline set of observations, including a blood pressure, looking for any sign of hypertension, and a resting pulse oximetry. I'd then like to request an overnight sleep studies, and in regards to the palpitations, I'd want to request a baseline ECG and a TSH level. In regards to the potential acromegaly, I'd want to do a baseline insulin-like growth factor, and I'd expect this to be raised. Following this, I'd wish to do a glucose tolerance test, and I'd expect this to show failure of suppression of growth hormone. Following this, I'd want to request an MRI scan of the brain with specific pituitary views.
What other organs can be affected in acromegaly?
Several organs can be affected, the most important of which are the cardiac system in terms of potential cardiomyopathy and ischemic heart disease. Patients can develop hypertension and type 2 diabetes, and importantly, visual impairment can result from acromegaly, and this can have important driving and social consequences.
Can you explain why patients do get visual disturbance?
Classically, bitemporal hemianopia occurs, and this is because of compression from the adenoma on the optic chiasm.
What treatments are available for such patients?
The mainstay of treatment is that of surgery, and that's via transsphenoidal resection, and that aims to be curative. Second line medical therapy includes somatostatin analogues, including octreotide, and second line agents include bromocriptine. Lastly, if these fail, radiotherapy directly to the pituitary gland can be an option.
What are the potential complications of surgical intervention?
The main complication of a resection is that of panhypopituitarism, and this would be important to warn the patient of this before surgery.
You mentioned that this patient may have obstructive sleep apnea. Why is this associated with acromegaly?
Acromegaly causes soft tissue swelling in the face and around the throat, and this can lead to respiratory compromise, especially at night when the patient lies down.
Do you know of any scoring systems that are used to classify how sleepy someone is if they have obstructive sleep apnea?
The main scoring system that I'm aware of is the Epworth Sleep Score, which is out of 24, and I believe that a score of over 11 may be indicative of obstructive sleep apnea. Additional scoring systems that we could look at are the Stop Bang questionnaire.
What is the actual mechanism of obstructive sleep apnea that leads to daytime somnolence in these patients?
While sleeping, these obstructive episodes cause a reduction in the patient's saturations and an increase in the heart rate, causing the patient to wake up. These frequent arousals can impair deep sleep, and therefore patients suffer from unrefreshing sleep.
How would we treat this lady's obstructive sleep apnea?
My hope would be that a surgical resection of the adenoma would lead to a reduction in soft tissue swelling in the mouth and neck, and hopefully this will result in the obstructive sleep apnea resolving in the interim, or if symptoms did continue after surgery, we could consider CPAP.
Thank you.
Thank you.
Acromegaly is a hormonal disorder that develops when the pituitary gland produces too much growth hormone, due to a tumour in almost all cases. There are many signs and symptoms, and your examination should include demonstrating some of the key features of acromegaly. Firstly, notice the general appearance of the patient, and then examine the visual fields, as well as some of the other cranial nerves, especially nerves 3, 4 and 6. A pituitary tumour can press on the optic chiasm, resulting in a bitemporal hemianopia. Examination of the hands should also be performed, as well as assessing the muscle strength in the limbs, as proximal myopathy can occur. Features of acromegaly include a prominent supraorbital ridge, nose and lips, a pronounced jawline, and macroglossia or large tongue. Enlarged hands with thickened skin also occur. Photographs may be brought in by the patient showing how their appearance has changed over the years. Examination may also reveal other endocrine features, such as a goiter or gynecomastia. Growth hormone levels are usually very low in normal adults, but can go up in response to stress. Growth hormone levels and blood glucose levels are connected, and a glucose tolerance test can be diagnostic. In a normal individual, a high glucose level results in growth hormone levels being lowered. In acromegaly, however, the growth hormone level fails to suppress with glucose and may in fact show a paradoxical rise. Random growth hormone levels are unhelpful. However, an insulin-like growth hormone factor 1 or IGF-1 level reflects the mean growth hormone level and is useful in diagnosis. 25% of acromegalic patients also have associated diabetes, and this also may be picked up on the glucose tolerance test. The pituitary tumour can compress the optic nerve, and visual field defects are very common. High-resolution CT scans are virtually always normal, and the imaging modality of choice is an MR scan. Pituitary function is either partially or completely lost, resulting in hypopituitarism. Treatment options available are transsphenoidal surgery and subsequent radiotherapy if excision is incomplete, or if the growth hormone levels are not normalized afterwards. Often radiotherapy is given afterwards, as the tumour can frequently occur, or radiotherapy can be given to patients alone if the patient is not suitable for surgical intervention. Somatostatin is a growth hormone inhibiting hormone, and a somatostatin analogue, such as octreotide, can be administered subcutaneously. They reduce growth hormone levels by up to 90%. A growth hormone receptor antagonist, which can normalise IGF-1 levels, can also be used. It, however, does not reduce the growth hormone secretion or stop tumour growth. It is reserved for patients with ongoing disease despite surgery, radiotherapy, and other medical therapies.
Good morning.
Good morning.
My name's Dr. Farrant. Can I confirm your name, please?
Yeah, it's Tony Robinson.
Nice to meet you, Mr. Robinson. I understand you've come here with some pain in your abdomen, is that right?
Yeah.
Do you want to tell me a little bit more about it?
I'm feeling nauseous, getting waves of nausea,
Okay.
and my urine stream's not very strong, and also it's darker than it normally would be.
Okay. So let's talk about the nausea first of all. How long's that been going on for?
Probably 2 to 3 weeks now.
2 to 3 weeks, okay. And have you actually been vomiting?
No, but I just feel like I'm going to.
Okay. And how many times a day do you feel that you're sort of getting nauseous?
Probably 2 to 3 times.
2 to 3 times a day. And how long does it normally last for?
A matter of seconds.
Seconds. Okay. So it's coming in waves and then going?
Yeah.
Okay. Has it been getting worse over the last sort of 2 to 3 weeks?
Not progressive worse, no, it just seems to be staying as it is.
Staying as it is. Okay. Has your appetite changed at all?
Yeah, my appetite's not great at all, which I'm putting down to the fact that I'm feeling nauseous.
Right, okay. What about your bowels? Have they changed at all?
No, my bowels are okay, yeah.
Bowels are good. Okay. And you said sort of your urine had changed.
Yeah.
Is that sort of because you've not been drinking as much? Or?
No, I do drink a lot of water.
Right, okay. And so the volume of urine you've noticed has decreased?
It's decreased, and like I say, it's also got darker, and the power of the stream is lessened. And
then what about sort of any pain down below, pain when you pass water?
No, not really, no. Slight pain, not when I pass water, but there's a slight pain over my kidney transplant.
Okay. I'll ask you about your transplant in just a second. When you say your urine has got darker, have you noticed any blood in the urine?
No, not blood, no.
Okay, so it's just sort of a more sort of like brown, orangey brown
yeah.
colour. Okay, fine. And you said you got a kidney transplant.
Yes, yes.
Tell me a little bit more about that.
I had it in 2005.
Okay.
And it was put down to the fact that I was taking an anti-inflammatory drug called diclofenac.
Okay. What were you taking the diclofenac for?
I suffered with gout.
Okay. And how long were you taking that for?
2 to 3 years.
Right. And then, so you've had the kidney transplant, and then have you been all right since then?
No, I was put on a steroid after the kidney transplant, which caused vascular necrosis.
Okay.
Which means I've had to have a new hip.
A new hip replacement?
Yeah.
Okay. Are you still taking steroids now? Or
No.
What medication are you taking?
Take tacrolimus, Prograf, and MMF, which is mycophenolate.
Mycophenolate.
Yeah.
Okay. And have your levels of that sort of been all right recently?
Yeah, recently, yeah.
So they haven't changed your doses at all or anything like that?
No.
Okay. And have you noticed that you've got a tremor at all?
No, I've been okay like that.
No tremor. Okay. Any sort of visual problems?
Just generally getting older, I think. I started to wear glasses for reading.
Okay. And any sort of problems with weakness in the limbs at all?
No.
Okay. Good. Obviously, the kidney itself, is that tender, did you say?
Yeah, it's slightly tender, yeah.
You
know, when I put my trousers on, I tightened my trousers, I felt twinges of it, yeah.
Right. And has that been happening over the last 2 to 3 weeks, or is that something that precedes all of this?
No, it's sort of happened at once.
Right, okay. Is it sort of hot as well, or is it just tender?
It's not. Yeah, it's only tender to the touch. When I touch it, it feels tender, but any other time, no.
Fine.
I'm not aware of it.
You're not aware of it the rest of the time?
Yeah.
Okay. And is the scar all right? That's not sort of causing you any bother?
No, I mean, it's 14 years old now, so, yeah.
Good. Okay. When was the last time all of your bloods were checked?
A month ago.
A month ago. And those, so the the creatinine levels and all the sort of the tacrolimus levels and those things were all right a month ago?
Yeah.
Okay, good. And you've not had any problems over the years with the levels being abnormal, have you?
No, they've been very steady over the last 14 years.
Okay, good. Other than the kidney transplant, I know that's a lot to have had done. Do you have any other medical problems that I need to know about?
I've had a new hip.
Yeah.
I've had a new aortic root and valves.
Okay.
I've had part of my stomach removed.
Okay, so you've had a lot going on over the years.
Yeah.
And do you drink?
Yes.
How much do you drink?
Probably 2 pints a day.
2 pints a day. All right. And do you smoke at all?
No.
And have you ever smoked?
When I was in my 20s, yeah.
How long did you smoke for?
Probably about 6 or 7 years.
Okay. How many a day did you used to smoke?
No more than 10.
Okay. And are you on any other medication than the medications we discussed earlier?
Bisoprolol.
Okay. Bisoprolol, yeah.
And warfarin.
And warfarin. So that's for the heart. Warfarin's for the heart valve.
Yes.
Okay. And obviously you come to see us today. What are you worried about?
The fact that my kidney could be failing. I'm passing darker urine. I feel fatigued.
Is it affecting you day to day?
It's causing me a lot of concern, which is affecting me which is affecting my appetite, which is affecting pretty much everything. Yeah.
Yeah. Okay. Have you lost weight recently?
Yeah.
Right. Okay. What do you do for a job?
I'm not working.
You're not working. Okay. Fine. So I think probably at this point the best thing for us to do is to move over to the bed so that then I can examine you and just get a better idea of the kidneys and sort of go from there if that's all right. So if we can just get you to move up to the bed, and what I'll need you to do is just take your shirt off as well.
Yeah.
Then we'll proceed with the examination. All right.
Okay, that's great.
Thank you. Right. So I'm just going to have a quick examination of you now, if that's all right. First of all, I'll just have a quick look at you. Can I just get you to take a nice deep breath in for me? And out. And give me a cough. Okay. I'm going to have a look at your hands now, please. And turn them over. And just put them straight out in front of you like that for me. And turn them over. And turn them back over for me. Just hold them like that. And relax for me. Can I just get you to pull down on one of your eyelids, please? Okay. That's great, and relax for me. Okay. Now what I need you to do is just open your mouth for me. And lift the tongue. And can you pull down on your bottom lip for me? Okay, that's great, and relax. Just have a quick feel of your pulse now. And relax. Rest your head back for me if you would, and just look towards the wall. So, do you have any pain in this part of your abdomen?
No, not there, no.
I'm just going to press on it, all right? Okay. All right, and just look forward for me now. So I'm just going to have a quick look at your chest now, all right?
Okay.
Okay. Quick feel of your heart. And have a quick listen to your heart. Can I just get you to sit forward for me now, please? Just going to have a quick feel of your neck. All right. Give me a swallow. Right. Now I'm just going to have a quick listen to your lungs. Deep breath in for me, please. And out. And again. 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 And out. I'm just going to lie the bed down now, alright? So you just stay sat forward. Okay, and then we're just going to lie you down now, alright? Okay, so I'm just going to have a look at your abdomen now, alright?
Okay.
And I know that the area over the transplant's tender, alright? I'm just going to have a feel of everything else first, and then I will have to press around that area. If it's too tender, let me know.
Okay.
Okay? So you said earlier on that you'd been losing some weight.
Yeah.
How much weight do you think you've lost?
I've gone from 65 to 55 kilograms.
So it's quite a lot of weight loss.
Yeah.
How long's that been over?
Probably about a month and a half.
Over a month and a half. Okay, that's a quick weight loss. And have you noticed any swelling anywhere?
No.
Do your ankles ever swell?
They used to pre-transplant.
Okay. And is that tender there?
Not really, no.
Not really. Okay, that's good. Deep breath in for me. And out. And again. 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 And out. Last one. And out. Okay. Just roll towards me slightly now, if you would. That's great. And roll back. And with the other one, just roll the other way slightly. And roll back. And relax for me now. Okay. Just gonna have a look at your legs now, alright?
Okay.
Okay. Do you want to just sit up for me?
Yep.
There you go, I'll just relax back. So, I know you said you were concerned about the kidney,
Yep.
alright? I think we need to do a few more tests just to check everything. So, we'll do some blood tests, alright? And we'll just check your urine,
Yep.
and then I'll come back and have another chat to you.
Okay, thank
Alright.
you.
Thank you. So to complete my examination, I'd like to do a full set of bedside observations. I would like to do a urine dip, check the hernial orifices, and given the history of rapid weight loss, I'd like to do a PR with the patient's consent. Thank you.
Thank you. Could you summarise this complex case, please?
So Mr. Robinson is a gentleman who initially presented with gout and took a prolonged course of non-steroidal anti-inflammatories in the form of diclofenac. And unfortunately, he had the complication from the non-steroidals of developing acute renal failure. This led to him requiring initially renal replacement therapy through peritoneal dialysis. That was evidenced by the scar on his abdomen suggesting a tunnelled dual lumen catheter for peritoneal dialysis, and then sometimes called a Tenkoff catheter. And then he also had a Rutherford-Morrison scar in the left iliac fossa, suggesting that he had a renal transplant done. It appears that from the history, that the medication used for anti-rejection is tacrolimus and mycophenolate, though he has also used steroids in the past for transplant rejection. Unfortunately, he's had a complication from the steroids of developing avascular necrosis of the hip, which required a hip replacement. Furthermore, he's had a thoracic aortic aneurysm, which required an aortic root replacement. So he's got a new metallic aortic valve, and which is audible on examination from the end of the bed, and also there's a metallic second heart sound on examination. His main concern today was that the transplanted kidney is not working as well or is failing. That's evidenced by his nausea that he's been suffering from, and also the decrease in urine output and the mild tenderness in the left iliac fossa. I had to say on examination, I wasn't able to elicit any tenderness. The transplanted kidney was also not warm, it was cool to touch, and there wasn't any signs of failure of the kidney with regards to volume overload. His ankles were nice and skinny, there was no pitting edema. Also, I couldn't see any evidence of uremia. So I couldn't, from my examination, elicit any signs that the kidney was failing, though I would like to do further investigations to confirm that.
What investigations would you do at this stage to interrogate the transplanted kidney?
First of all, I would do a urine dip, and I would also do a routine set of bloods, particularly looking at the gentleman's urea and electrolyte levels to check that the creatinine hasn't changed from his baseline. I'd also want to do a tacrolimus level to make sure that his transplant rejection medications are within range. And then there are further tests that we could do just to check the blood flow. So we could do a CT scan with contrast to look at the renal arteries. And then, if I was really concerned, we could think about maybe doing a kidney biopsy to make sure that there's no evidence of rejection going forward.
You mentioned a CT with contrast. Would there be any contraindications to contrast in this case?
So it would depend on the gentleman's creatinine level. I would want to make sure that the creatinine level was good, because any sort of risk of reduction in EGFR, particularly in a transplanted kidney, could be significant.
And he did mention significant weight loss. In this setting of someone who's immunosuppressed, would that make you concerned about anything in particular?
So yes, first of all, given his immunosuppression, I'll be concerned that there's an infection on board. Also, particularly in immunosuppressed patients, you think about skin malignancies or even a post-transplant lymphoma. So I would want to make sure I screened for those in this gentleman.
The cause of the renal failure in this case was chronic use of non-steroidals. Do you know of any other complications of chronically using non-steroidal anti-inflammatory drugs?
So it can irritate the gastrointestinal lining. Patients have been known to have GI bleeds as a result of chronic non-steroidal use. Obviously, there's renal failure, which is evidence in this case. And chronic non-steroidal use has also been linked with cardiovascular disease through MIs and strokes.
Thank you.
Thank you.
This is clearly a very complex case, handled very well by a competent candidate. There is a lot of information in the history, and the skill is to focus on the main issues, which are the renal transplant. As the symptoms suggest, this could be failing. And this is the patient's main concern, which is addressed by the candidate well. Significant weight loss is a worry, and there may be a malignant process here. The cause of the renal transplant is ascertained from the history, which is a recognised complication of non-steroidal usage. The candidate explored the use of the immunosuppressive medication that the patient was taking and any side effects that included avascular necrosis of the hip, secondary to previous steroid usage, and the demonstration of a tremor secondary to tacrolimus. The focus of the examination should again be the abdominal system and interrogation of the transplant, looking for tenderness. This should be done sensitively by asking and observing the patient and listening for a bruit. Also, close assessment of the fluid status of the patient is of utmost importance. The fact that the patient has had significant heart surgery and has an aortic valve means that the candidate ruled out any aortic regurgitation in a very focused way. A good candidate continues to talk to the patient during the examination, keeping a good rapport, and can clarify any of the history, or indeed certain findings may lead to further questioning and new lines of inquiry. This is perfectly valid and demonstrates how a true consultation may occur in reality. The candidate summarises the patient's concerns at the end, and an agreed action plan is taken going forward.
Good afternoon.
Good afternoon.
My name's Dr. Farrant. Can I just confirm your name, please?
Yeah, it's Dave.
Nice to meet you, Dave.
Thank you.
So, your GP has sent you here because he said that they'd noticed something wrong with your eyes.
Yeah, that's like a bit of a discolourment, saying that they're very blue kind of thing. Yeah, just concerned me really.
Yeah, okay. Have you had that all your life, have you known? Or
yeah, it seems to be as a child kind of thing, but it's only sort of like been picked up really
picked up
at
on
the
recently.
moment. Yeah,
Okay.
they just might go a certain more bluer when I'm distressed or whatever. Or
Okay. And have you had any problems with your vision at all?
not had any problems with my vision.
No, so it's just the discoloration around the eyes.
Yes, yeah.
Okay. And have you got any other medical problems?
Well, I've had a series of fractures as well.
Okay. So how many fractures have you had?
I've probably had over about 30 fractures.
Really?
Yeah.
Okay, that's a significant number of fractures to
Yeah.
have. Any sort of parts of the body in particular that have been breaking?
Yeah, it's been my legs really, and over the few years they've sort of like my legs have deformed a little bit with the bones kind of thing, and taken longer to heal, more so than other, the people kind of my fractures.
So they take quite a long time to heal.
Yeah.
That's interesting. Okay. And you said the eyes have been there since childhood. Did you have a lot of fractures in childhood?
Yeah, a lot of fractures, yeah, and just sort of simple ones of just sort of like falling over really, and nothing,
So it's not like you've fallen out of a tree 30 times and you've broken your leg? It's...
No, not at all, just very sort of simple as a child, sort of playing, as a toddler, just falling over and...
okay, fine. So it's the legs and, your arms as well?
Yeah, I've had a fracture to my collarbone as well, and my arm about 4 or 5 years ago. That was quite a serious. That broke in 3 places.
Oh, okay, that must have been difficult.
Yeah, and as I said, that wasn't just necessarily a very big fall. It was just...
You just tripped over?
Just tripped over, really, and it broke in 3 places, yeah.
Oh, gosh, okay. And you said you've had sort of multiple fractures in your legs. How's that affected your walking and things?
Yes, it has, because I've had a significant amount of fractures to my right leg, And a couple of years ago, I had a hairline fracture to my spine, and I couldn't understand how it happened. And basically, it was found by seeing someone that my leg was considerably shorter than the other.
Okay, as a result of the fact that your leg's deformed.
Yeah, yeah. So
Right.
now I have an instep in this leg, so it's brought my spine
And has that made your walking easier?
yeah, a lot more easy. Yes, yeah, yeah.
I do notice that you've got a stick. Have you? How long have you needed to use that for?
I've for about 20 years with
Really?
a walking stick. Yeah,
Okay.
yeah.
Right. So we've got multiple fractures, and we've also got some discoloration in the eyes. Have you had any other problems at all, like maybe with your hearing?
Not as much there. I've had a few sort of heart palpitations as well.
Okay.
And a bit of sort of like breathlessness kind of thing, but it's it doesn't last for long.
Right.
And it sort of kind of just goes kind of thing.
So any pains in the chest?
Not necessarily pain, no.
But you can just sort of feel your heart fluttering, is that right?
Basically, yeah.
Okay. And does it get worse if you exert yourself?
It can do sometimes if I've just done a lot of walking or strained myself, done anything more out of the ordinary than I should have done.
And if you climbed a flight of stairs, would it get worse? Do you think?
If there was a certain 2 or 3 flights of stairs,
then
possibly,
it would
yeah.
do.
Yeah.
And have you ever got dizzy with these palpitations before?
No, I haven't really suffered with dizziness.
Okay.
Yeah.
And you've not blacked out at all? Or?
No, I've not blacked out. No.
Good. Okay. Right. And the breathlessness, is that associated with the palpitations? So when they come on, then you get breathless?
Yeah, get breathless, yeah, yeah.
Okay.
Yeah.
Fine. And any problems with the bowels at all? Are they all right?
Yeah, I've had a few stomach issues in the past. That's probably speared on since when I got into my 40s, really.
Right.
Kind of thing, yeah.
Okay. Are there any problems passing water at all? Or?
That seems to be okay at the moment.
That's
yeah,
okay,
yeah,
good.
Yeah.
Is your appetite all right?
It comes and goes. I don't think it's as big as it sort of like used to be, but yeah, it comes and goes with my appetite kind of thing, yeah.
And are you taking any medication at the moment?
I'm not on any medication at the moment, no.
Okay,
no.
good. And do you have any other sort of medical problems that I need to know about?
That's really the only sort of...
Nothing at the moment?
Yeah,
okay,
yeah.
Fine. What about smoking?
I've never smoked, no.
Okay.
I've never smoked.
Good.
No.
Alcohol?
I do drink, but I'm a social drinker kind of thing.
Okay.
I don't drink in the house. I just have 4 or 5 bottles of Corona if I'm out with a few friends.
Okay, and how often do you do that?
It can sometimes it can be 2 or 3 weeks before I have a drink, or maybe
Okay.
just depends what's on that sort of month. If I've got christenings and
yeah, that makes sense. Okay, and is there anything you're particularly worried about?
just more really about why I sort of get sort of like the breathlessness and stuff like that. And,
I can see that must be quite worrying.
Yeah, it is, and just that really. It just kind of scares me.
Is it affecting you day to day?
It can do sometimes, yeah. And then obviously I'm a bit worried about with the eyes kind of thing as well,
Okay.
Yeah.
And are you working at the moment?
I'm not working at the moment. I had to give that about 4 or 5 years ago due to ill health.
Was that because of all the difficulties with walking? And
yeah,
things like
it
that?
was kind of thing. It was just taking its toll on me really with my back and the stress of it, and then I had other things, personal things going on in my life and stuff like that. So
okay. Thank you for telling me all of that. I think probably the best thing for me to do now is to move to examine you. All right. So first of all, I'll just do an examination of your face and have a look at your eyes, and then what we'll do is we'll just have a look at your back, and then I'll get you on the couch. We'll need to get you to take your shirt off so I can have a listen to your heart as well.
okay.
All right.
Okay.
Okay. So I'm just going to have a look at your eyes now.
Okay.
So can I just get you to pull down on your eyelid for me, please?
Yeah, sure.
That's great, thank you. So now I'm just going to have a look in the back of your eyes.
Okay.
It's going to involve me getting quite close. What I'd like you to do is just pick a spot on the wall, all right? Keep looking straight at it, and I don't mind you blinking, but just try not to move your eyes, all right?
Sure.
Okay. Okay. I'm now just going to test your hearing, all right?
Okay.
So, first of all, what I'd like you to do, I'm going to say a word into one of your ears while making a noise in the other one. I just want you to tell me what the word I said was, all right?
Elephant.
Giraffe.
Giraffe.
Okay. So, this is a tuning fork. What I'm going to do, first of all, is make a noise and then place it on your forehead. I want you to tell me if it's louder in either of the two ears, okay?
In the right ear.
Okay. And now what I'm going to do is make a noise, place it on the outside of the ear, okay? And then move it and touch one of the bone parts of your ear, okay? I want you to tell me if it's louder on the outside or when I'm touching your head, all right? Which was louder? On the outside?
On the outside, yeah.
Okay.
Yeah.
And the same on the other side?
The outside.
Okay, good. Okay, so now what we need you to do is stand up and just, with your back to the wall, get close to the wall just so I can have a look at the curvature of your spine.
Okay.
I need you to take your top off for that as well, if that's all right.
Okay.
Okay. Okay. That's great. And just relax your arms now down for me. Just have a look at you. Okay, so what I'd like you to do now is just get yourself on the couch, if that's all right.
Yeah.
Thank you.
Sure.
Okay, so I'm going to have a look at your hands first of all now, and then what I'll do is I'll have a quick examination of your heart as well. So can you just stick your hands out in front of yourself for me? And turn them over. And back again. And can you just cock your wrist back for me? And now with the other hand, I'd just like you to pull back on your fingers and just show us how far back they go. Thank you. And now, if you could just turn your right wrist over and then just try and grasp your fingers around your wrist for me, if you could. That's great. And relax. Now, could you just pick up your skin and sort of pull it up for me? Let's just see how elastic your skin is. Okay, great. And relax for me now. Right. Just going to have a quick feel of your pulse now, if I may. Have you got any pain in your shoulder?
No.
So what I'm going to do is I'm just going to lift your arm up. Let me take the weight of the arm and let me do all the moving, okay? Okay, that's great. Relax. And just relax your head back for me. Just going to feel the pulse in your neck now. Okay, and just look towards the wall for me if you would. Have you got any pain in your abdomen?
No.
I'm just going to press on it. Okay, and relax. Just let me see your teeth. That's great. Just going to have a look at your chest now. And sit forward for me. Deep breath in. And out. And 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 in. And out. Okay, and just relax yourself back for me. Just gonna have a look at your legs now. If you just pull you. Okay. So I know you were concerned about the recurrent fractures that you'd been getting and the discoloration in your eye. And I think this is likely related to a condition called osteogenesis imperfecta. Now, to confirm this, we're going to need to do some more tests. So we'll need to do some bloods, all right, particularly to look at the calcium and phosphate levels in the body. We'll need to do some genetic testing to see if this is something you've inherited. And also we should really send you for some scans, some x-rays, to have a look at the bones and have a look at their makeup. All right? But we'll talk to you about all of this at a later date.
Thank you.
Thank you. So to complete my examination, I'd like to do a full cranial nerve examination and do a full cardiovascular examination. Thank you.
Thank you. Please can you summarise the important aspects of this case?
So this gentleman has presented with a blue discoloration of the eyes and recurrent fractures which have happened since childbirth. He also reported that he'd been suffering from palpitations and some abdominal discomfort. On examination, he was of short stature with a barrel chest, and he had an obvious deformity in both of his legs. He walked with an abnormal gait, and there was evidence that he'd needed an implant in his shoe, which he told us about. And he also had joint hypermobility. All of these, I believe, are in keeping with a diagnosis of osteogenesis imperfecta.
What investigations would you perform?
So, starting off, I would like to just do a full set of bloods, particularly looking at the bone profile, so the calcium and the phosphate levels. We'd also like to check a vitamin D level. I think it'd be important in this setting to do some genetic screening because osteogenesis imperfecta is predominantly an inherited condition. I would also like to do a full set of x-rays and do a bone DEXA scan to look at the bone density in both the hips and the lower back, and I would like to do an echocardiogram.
And obviously, depending upon the results of your tests, would you recommend any specific treatments for this chap?
So it would very much depend on the results. If the calcium and the phosphate levels or the vitamin D levels were low, I would replace those. Also, if the bone DEXA scan had shown that the bone density was depleted, then we could consider bisphosphonate therapy. I would also like to have this gentleman re-reviewed by the orthotics team to ensure that if he needs any further implants in his shoes to help with his walking, that was done. And importantly, I think given that he clearly needs a walking stick at the moment, review by the physiotherapists would be appropriate for him.
You examined this gentleman's heart and you also mentioned an echocardiogram.
Mm-hmm.
What were the reasons for this?
So there is an association with the bicuspid aortic valve in patients with osteogenesis imperfecta, and they can develop aortic regurgitation when there's a lack of collagen within the valve. So over time, aortic regurgitation develops, and patients can become fluid overloaded and can sometimes require a valve intervention because of it.
You mentioned osteogenesis imperfecta is an inherited condition. Can you expand on that?
So it's inherited predominantly in autosomal dominant fashion. There are 8 different variations of osteogenesis imperfecta, and in some cases it can be a condition that develops spontaneously, though that's normally the more severe forms of the condition.
Just to go back to one of the treatments you mentioned, bisphosphonates, are there any side effects to chronic bisphosphonate use?
So first of all, when patients take bisphosphonates, it's important that they're sat upright and they do it after a meal, because it can be very irritating to the gastric lining. But also it's associated with osteonecrosis of the jaw, so it's important that patients have regular dental checks and they have an x-ray of the jaw before commencing therapy.
This gentleman is middle-aged. Is that the normal age to be diagnosed with osteogenesis imperfecta, or would you expect it to be earlier than that?
So classically I would expect it to be earlier. Normally patients present with multiple fractures in infancy, and they're picked up by the paediatric team. It's also important in children who present with recurrent fractures to be screened for non-accidental injuries, because it can be a safeguarding concern in children who present with recurrent fractures. And then osteogenesis imperfecta is something that should be screened for after multiple fractures.
Thank you.
Thank you.
In this case, the patient presented with some symptoms of palpitations and a referral with changes in the sclera and a past history of fractures, which should immediately raise the possibility of osteogenesis imperfecta. This is a group of predominantly inherited conditions that mainly affects bone formation, leading to fractures. Other manifestations can include discoloured translucent teeth, known as dentinogenesis imperfecta, and hearing impairment, reflecting the involvement of the middle ear bones. Both were looked for by the candidate in this case. The impact of the condition, which can be demonstrated during the examination section, can also include small stature, spinal scoliosis, or any bowing of the long bones. Joint hypermobility and skin hyperlaxity were also looked for. The association of the condition with heart complications was suggested by the patient's presenting symptoms, and a focused cardiac examination looking for aortic regurgitation would be expected. The patient's concerns were addressed, and the ultimate diagnosis of osteogenesis imperfecta was explained well to the patient. There was a clear plan going forward after the interaction, which demonstrates to the examiners that the patient will feel that their concerns have been dealt with.
Hello there. My name's Gavin Britton. I'm one of the medical doctors in clinic today. Is it Kelly Dillon?
Yes.
I've been asked by your GP to have a chat with you about breathlessness. Is that right?
Yes.
Can I start by asking your age?
65.
And can you tell me a bit more about this breathlessness?
Well, it's been going on for quite a while, and I feel like my heart is beating very, very fast.
Okay.
And it makes me breathless. And obviously I think I'm panicking a bit as well, but it's getting worse. It's not getting any better.
And when did this first start, do you think?
The breathlessness started a good few months ago.
Okay.
But the palpitations, I have been having them for a very long time.
Okay, fine. And this breathlessness, you mentioned it's getting worse. Is there any particular activity or time of day when you notice this?
It just comes on.
Okay. And is it more noticeable with activity or just at rest?
Even at rest, I notice it quite a lot, but then I notice the palpitations as well at rest.
Okay. And has it affected your level of mobility?
Yes, it has. I'm a little bit scared of going too far and walking too far.
Okay.
Because I can feel it coming on.
Fine. And how far can you walk before it starts to come on?
Not very far, actually.
So in metres or yards?
A metre, and I just feel, yeah, or a couple of metres,
Fine.
and I just feel it then.
Okay.
And then my heart really beats very fast.
Okay. And previously, before this started, could you walk a lot further?
Yes, I would say that, yeah.
Fine. So just to ask you a bit more about the feeling of your heart beating that you mentioned, have you noticed if that's regular, if it does it in a certain pattern, or is it quite irregular?
It's all day long,
So it's
all
constant.
day long, even in when I'm in bed, it wakes me up.
And is it quite fast? Or is it
Very
just
fast,
noticeable?
yeah.
Okay.
I feel like it's coming up into me throat and my mouth,
Okay.
and I feel like I'm going to faint.
Have you fainted at all?
No, I've never fainted, but I feel like so lightheaded, I have to sit down.
So you've had some light-headed episodes
Yeah,
as well? Okay.
yeah. Had some pains as well up my arm,
Okay.
and some at the back of my neck.
And are they still there now, or have they...
They come and go all the time.
And what does that pain feel like in your arm?
It feels like lead,
Okay,
and like a tingling as well. I get a tingling in my hand.
okay. And the same pain in the back?
Yes.
And typically how long does that stay for?
Oh, it can stay for a while. Stays for a while.
So minutes or hours or days?
Hours.
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 And does anything bring on that pain?
No, just comes.
And does anything get rid of it?
No, I just sit and rest.
Okay. Do you have any breathlessness during the pain?
Yes, I do.
You do?
Yes, I do.
And do you ever feel sickly with it?
Yes, I do.
Okay.
Yeah.
Or sweaty?
Sweaty, very sweaty. Yeah.
Okay, fine. Just to ask you a bit more about your background, if I may. Are there any medical problems you've been told that you've got off any doctors or nurses?
Yes, I've been told I've got Ehlers-Danlos syndrome.
Okay. And have you ever had to have any treatment for that?
I've had a lot of treatment for that, yes, over the years.
And what sort of things have
I've
you
had trigger thumbs. I've had to have operated on both my hands.
Okay.
I've had carpal tunnel on both my hands.
Okay.
I've had quite a lot of abscesses and infections removed from the right side of my, under my arm.
Okay.
And down the side of my ear.
Okay.
I think that's about it on that.
Have you ever had any problems with your heart or your blood vessels, for instance?
Not that I know of.
Okay. Any other medical problems?
I've got osteoarthritis. I've got fibromyalgia.
Okay.
I've had a TIA.
Okay.
And I know I've got something going on with my thyroid.
Fine. And what medication do you take at the minute?
At the moment, I'm just on a statin and some painkillers.
Okay. And do you have any allergies?
Strong painkillers make me very ill, like anything with codeine in.
Okay.
And I suffer with hay fever.
Just to ask you a bit more about your background, if I may. Who do you live with?
I live with myself.
Okay. And do you manage everything yourself, or do you need support from others?
Well, my daughters come up and help me. They come to my home.
And what do they help with?
Quite a lot of things because of me arthritis, opening things and
Okay.
keeping my house clean, and they take me shopping.
Okay. Do you manage to do the shopping when you're there? And
Not on my own. I have to go. I have to go with my daughters.
And are you able to dress yourself?
Most of the time, yeah.
Okay.
Or depends if I'm having a bad time,
Okay.
if I'm not well, or if I've had something happen to me.
Okay. Fine.
Then I could be poorly for weeks,
Okay.
especially if I hurt myself
Okay.
because of the Ehlers-Danlos.
Do you use any mobility aids?
Just got the usual things like for the taps and
Okay.
for opening things.
You don't use a stick or a frame?
I've got a walking stick.
A walking stick.
Yeah.
Okay. Do you drink alcohol?
No, not really.
How much would you drink in, say, a typical week?
None in a typical
Okay,
week.
fine. Do you smoke?
Used to.
And when did you last smoke?
23 years ago.
Can I ask how long you smoked for?
From being about 13 till about in my 40s.
And typically, how many would you smoke in a day?
20 at
Okay.
least.
Okay. And do you work?
Not now, I've retired.
What did you do?
Worked at the school dinners.
Okay. Are there any problems that run in the family, such as heart problems or lung problems?
No.
No. Good. Anything else that runs in the family?
No.
Okay. Just to go back to a couple of those symptoms, if I can, is there anything else that you've noticed recently?
No, not really.
Okay.
Just that I'm very concerned about what's happening with me.
Okay. So
I'm scared a bit really with it.
Is there anything that you're scared about?
That I might have an heart attack.
Okay. fine. I can understand that.
Yeah.
Must be quite concerning for you. And can just take a bit more time to ask a few more questions, then I'll go on to have a look at you.
Yeah.
And we can touch on that shortly if that's
Yeah.
all right.
Yeah.
Just about the breathlessness, have you ever noticed that you've got a cough with that?
No, I haven't.
And is the chest pain ever worse if you take a breath in or cough?
I wouldn't say no to that.
Have you had a fever or any night sweats?
Yeah, night sweats I've had.
You've had some night sweats, okay.
Yeah.
Have you noticed any lumps or bumps anywhere in your body, under your arm or in your neck?
Yeah, but I found that's through other things, through other infections that I've had.
Okay. Do you have any now?
No, not at the moment.
Okay. Have you noticed any weight loss at all?
I have lost a bit of weight, yeah.
How much do you think you've lost?
I think I've lost about a stone.
Okay.
Over about a year.
Okay, fine. Is that intentional?
No.
No. Okay. Any change in your bowel habit?
No.
Or any change with your bladder?
No.
Okay. Any rashes that
No.
we've not spoke about, or
No.
any joint pains that we've not spoke about?
I've got constant joint pains because of the Ehlers-Danlos loss.
Any of them new or changed in any way?
No, just as normal.
Just normal.
Yeah.
Okay. What I'll do now then, if it's okay with you, is we'll just move over to the bed and I'll have a listen to your heart. Start by having a look at your hands. You mentioned the night sweats. How long have they been going on for?
Good few months now.
And if you turn your hands over. And have you noticed any change with your appetite?
No.
If you turn your hands back for me. I'll have a feel of your pulse. And you can rest that hand down. Have you noticed any changes with your swallowing?
No.
And any blood loss from bowels, bladder,
No.
or from your chest, coughing up any blood, for example?
No.
Okay. Do you have any pain in the shoulder?
Yes, I do. Yes.
I would like to check for a collapsing pulse. What I'd like to do now is have a look at your neck. If you can rest your head back and turn your head to the left. Do you have any pain in your abdomen?
No.
I'm going to press on your abdomen now. And relax again. If you slip your glasses off and peel down one of your eyelids. Okay, and you can put your glasses back on. Now open your mouth. Tongue up to the roof of your mouth. Okay, and relax. Can I have a look at your chest?
Yes.
Okay, and is there any scars I can't see?
Yes.
Any scars on there that I
Yes.
can't see?
Yes.
Where are they? Just on the
And
lower half?
down.
Okay, fine. And any scars on the legs at all?
Yes. I've got some bruising.
Okay.
I've got quite a bit of bruising.
Okay,
There.
fine.
Bruising.
And if I can just have a feel of the chest? That's okay. Just have a feel there. Just put a hand on. I'll have a feel of your pulse. If I can have a listen around this side. Thank you. And if you can roll onto your left side, please. And come back. And then I'll have a listen underneath this side, please. Thank you. I'll have a listen in your neck. If you breathe in and out, and hold your breath. Thank you. And breathe normally. On the other side, breathe in and out, and breathe normally. okay, and relax. And lastly, if you can just sit forward, and if you breathe in and out, and hold it out. Thank you, and relax. That's okay. While you sat forward, I'll have a look at your back.
Right.
Are you able to lift up your top at all at the back?
Yeah.
I'll have a feel of your neck as well.
Okay.
Let's have a feel for any lumps or bumps. Okay, and then the other side. Okay. And if you can take a breath in for me, and out. And one more. Just breathe in, and out. Thank you. I'll have a listen to your back.
Okay.
Just take some deep breaths in and out. Have a feel of the bottom of your back. It's okay, you can relax back. And I'll have a look at your legs. Thank you. You mentioned earlier that you were concerned that you'd had a heart attack, and whilst I think this is unlikely, I would like to do a few investigations, including an ECG, so a heart tracing, to look into this further. When I examined you, I found evidence of an irregular pulse and a murmur of the heart, and I think it could be that it's these two that have caused your symptoms rather than a heart attack. The irregular pulse is something called atrial fibrillation, and in conjunction with the heart murmur, it could be that this is caused by, or at least partially in association with, your underlying condition of Ehlers-Danlos. I'd like to look into this further today by doing some blood tests, the heart tracing, and an echocardiogram, so a jelly scan of the heart, and then I'll talk to you about the results afterwards if that's okay.
Yes.
If you do have an irregular heart shown on the heart tracing, it may well be that we need to give you further treatment in the form of blood thinners, so anticoagulation. But I'll give you a leaflet in the meantime and we can discuss this in more detail later on.
Okay.
Do you have any other questions?
No, I don't think so.
Thank you. To complete my examination, I'd like to request urinalysis and a full set of observations.
Can you summarise this case for me?
This 65-year-old female presented with progressive breathlessness, chest pain and palpitations. On examination, there was evidence of a low-volume, irregular pulse, which was rate-controlled. The examination of her precordium revealed a pansystolic murmur, heard loudest in the mitral region, and radiated round to the axilla. There was no evidence of an opening snap, nor was there any evidence of congestive cardiac failure or bacterial endocarditis. Although there was evidence of pulmonary edema, I do not think this is linked, and there was no other evidence of peripheral stigmata of cardiovascular disease. There were clear features of Ehlers-Danlos with cigarette paper-like skin, and which was also fragile and clearly easily bruises. In summary, I feel this lady has atrial fibrillation and mitral regurgitation, and although mitral valve prolapse is more commonly seen than mitral regurgitation in the setting of Ehlers-Danlos, I think it could be that these two conditions are linked. The atrial fibrillation could have led her to have an increased risk of the TIA she's had in the past.
How would you investigate this patient?
So initially, I'd like to do some baseline blood tests, including a full blood count, looking for any evidence of anemia, and baseline kidney function, liver function, and cholesterol. I'd also like to do a clotting profile. I'd like to do an ECG, looking for evidence of atrial fibrillation, and to look for any evidence of previous myocardial damage. I'd like to confirm the evidence of mitral regurgitation with an echocardiogram, and given her breathlessness, I'd like to consider doing a chest x-ray today.
And if this lady is in atrial fibrillation, how would you treat her?
So I'd like to assess her CHADS VASC score, which in this current patient would be a 4 based on her gender, age, and in the setting of the previous TIA. The current guidelines are that females with a score of over 2 should be anticoagulated either with a vitamin K antagonist or a direct oral anticoagulant.
How would you choose between a vitamin K antagonist and a direct oral anticoagulant in this lady?
So this decision would be primarily driven by patient choice. I'd want to give this patient adequate information to make a relevant choice between the 2 different options. Vitamin K antagonists, whilst are better understood, have clear dietary restrictions and also have the frequent need for blood monitoring. Direct oral anticoagulant medications, although have been around for a few years now, some of which don't have reversal agents, and in patients who do have an increased propensity to hemorrhages, it may well be that we need to select an agent which we have a known reversal agent for.
What are the known complications of Ehlers-Danlos syndrome?
There's several complications. The most common is to do with the joints. Patients have hypermobile joints, and over time this can lead to joint deformity that requires corrective surgery. In the meantime, patients clearly may need analgesia and also MDT assessments. They are likely to require ongoing physiotherapy and occupational therapy input to maintain their activities of daily living. Other common complications can be split into cardiovascular complications, which can include mitral valve prolapse, mitral regurgitation, as seen in this case, as well as aortic regurgitation and cardiac conduction abnormalities. In the vascular subtype, there is a greatly increased propensity to hemorrhage, and this can be in the form of aneurysms and also in Ehlers-Danlos itself, gastrointestinal hemorrhage. Lastly, I would want this patient to have regular ophthalmology assessments, as there is an increased risk of glaucoma and problems with the retina.
Is there any specific treatment for Ehlers-Danlos syndrome?
So treatment is largely supportive, either with simple analgesia for any joint aches and pains, as well as occupational therapy and physiotherapy input. If there are specific complications such as aneurysm formation or joint deformity, these should be addressed as they arise.
And are you aware of the genetic inheritance of Ehlers-Danlos syndrome?
So the various different subtypes of Ehlers-Danlos carry different genetic inheritance patterns. Some can be autosomal dominant, others autosomal recessive, and there can be de novo mutations as well.
Thank you.
Thank you.
The symptoms were explored and expanded very well, and each individual symptom was taken in turn, and the patient's descriptions were clarified so that the candidate was confident he had understood the exact nature of the problem and how they affected her. The patient's current concerns regarding what might be the cause of her symptoms were addressed, and how she functions on a day-to-day basis was explored well. The past history of Ehlers-Danlos syndrome is clearly extremely important, and the findings of atrial fibrillation and heart murmurs are the likely cause of this patient's symptoms. The implications of this were explored in his answers to the examiner's questions. Ehlers-Danlos syndrome is a group of inherited conditions that affects connective tissue and is associated with defective collagen synthesis. This patient had lots of musculoskeletal problems related to her condition, but this was not the main focus of her current presentation. The different forms of the condition are associated with different outcomes, with vascular Ehlers-Danlos syndrome having a worse prognosis due to major bleeding. The weight loss she mentioned was explored well by the candidate to see if there were any other red flag symptoms that would suggest malignancy. The examination here focused almost entirely on the cardiovascular system, given the presenting features and the known complications associated with Ehlers-Danlos syndrome. The patient's concerns were addressed again towards the end of the consultation, and a plan for future investigation is an appropriate point to end with.
Good morning.
Morning.
My name's Dr. Farrant. Can I just confirm your name, please?
George Cooper.
Nice to meet you, Mr. Cooper. What is it you've come to see me about today?
Well, actually, it's my GP that's referred me here. I've been a bit breathy, having trouble catching my breath.
Okay. Why don't you tell me a little bit more about it? How long has it been going on for?
Well, it's been going on a few weeks. I've been I am reasonably active. I'm not working now. I'm retired, and I find myself just getting out of breath, just doing the simplest of things now. First of all, my main passion is golf. I love playing golf, and I can't do it. People describe it as it's a good way to ruin a nice walk, don't they? Golf, but no, I cannot walk. I can't pull my cart behind me well enough now. It just and the stairs in the house are beginning to get a bit difficult for me.
Okay. And you said this has been going for a couple of weeks?
Yeah. Well, it was. I say it might be a bit longer than that because I've been up. Well, it's more like a month actually.
Okay. And have you had a cough with it?
Not really, no.
Okay. And so is it only on exercise that you get breathless, or are you getting breathless when you're sitting down, or?
It's more when I'm doing things.
When you're doing things, you get breathless.
I like a bit of gardening.
But you can't deal with a garden.
I've got a tiny little garden, but I can't even push my little hand mower now without stopping every 5 minutes.
Right. Okay. And what about any other symptoms? Are you getting pains in your chest with it?
Well, when they come to mention it, it could be because I thought I was just getting a lot of wind lately, but yeah, there is a bit
like a heaviness in the chest.
Yeah. Like
Okay.
a bit of pressure.
Okay. Does that pain go anywhere else into your arm maybe, or into your neck?
Don't not at the moment. No,
Not at the moment.
So, no.
Okay, so it's just a heaviness in the
Yeah.
chest. Okay. And so that is that also when you exert yourself?
Well, it's sometimes, yeah. Sometimes when I'm sitting down, I don't like pushing myself too much at the moment, so I will take time out and sit down and just try and recover.
I think that's reasonable. Yeah. And clearly, this is something that's affecting you quite a lot. Okay, so just a few other questions. Do you suffer with acid reflux at all? Like sort of. No. Okay, good. And what about sort of palpitations or flutters in the chest? Have you been getting anything like that? Not really?
So, no.
Okay. What about dizziness? Have you been feeling dizzy at all?
Well, when I've been feeling a little bit dizzy at times. So.
Is that particularly when you're sort of doing the exercise and then the breathless comes on and then you get dizzy?
Yeah, top of the stairs. A couple of times I've had to hold onto the banister a few times just to steady myself. But I thought originally that's only because when you get up suddenly, that affects you, doesn't it?
Yes, but this doesn't sound like it's when you're getting up suddenly. Or is it?
Well, no, not really, no.
Okay. Now, sometimes when people exert themselves, you know, to the point of getting dizzy, they can black out. Have you had any sort of blackouts or falls recently?
I've stumbled a few times. There was a time the other week when I got to the top of the stairs and I thought I caught my foot. I must have tripped over the top of the step, I thought. But I was actually on the floor.
Okay.
So
that does sound like you might have blacked out there. Okay. So let me just ask you a few sort of more general questions. Other than this problem with the breathing and the pains in the chest, have you got any other medical problems that I need to know about?
no, not that I know of.
Good. Are you on any regular medication?
None.
Okay, good. Do you smoke?
No.
Do you drink alcohol?
Well, just the usual, isn't it?
Okay.
Just a couple of pints a week down at the golf club.
Okay, that's reasonable. And any family history of any medical problems? Heart trouble?
Oh, there's never been any heart trouble in our family, I can remember.
Okay, good. And what is it that you're particularly worried about?
Well, I can't live the way I'm used to living. Suddenly everything's sort of slowed me down. I can't move around. I like living where I live. I like having the stairs in the house, having the upstairs, but it's getting increasingly difficult to get at the top of the things.
I can see that. Okay. So, you know, I've got a rough idea about what might be going on, but I think what I need to do now is have an examination of you. Okay. So what I'll need you to do is slip your top things off, all right, get yourself on the couch, and then from there I'll have an examination. I'll listen to your lungs, have a listen to your heart, okay, and then once that's done I'll have another chat to you about where I think we should go next. All right?
Yeah.
Okay, so what I'm going to be doing now is having a quick examination of your heart and your lungs and having a general look at you. All right? So first of all, what I'd like you to do, just give me a nice deep breath in, please, and out. And give me a cough. Okay. Can I have a look at your hands now, please? And turn them over. And back over for me. Put your hand straight out in front of you, if you would. Okay. Relax that hand for me. You can have a look at your finger. And feel your pulse now. Okay. Do you have any pain in your shoulder?
No.
So what I'm going to do now is just lift your arm up. Let me take the weight of it, all right? Okay. Now, could you just rest your head back on the pillow for me and look towards that wall? Do you have any pain in your abdomen?
No.
I'm just going to press on it. Okay. Now I'm going to feel the pulse in your neck. Okay. Look forward for me. So could you just pull down on one of your eyelids for me? That's great. And open your mouth for me. Let me have a look. And lift the tongue, please. Thank you. I'm just going to have a look at the chest now. So, do you ever get problems with leg swelling?
No, no.
And what about at night? How many pillows do you need to sleep with?
Oh, I've just got my usual one.
And can you lie flat?
Yeah, not a problem.
Good. Just relax your head now. And just roll onto your left side for me if you would. And back onto your back for me. Sit forward for me if you would. And deep breath in. And hold. Breathe normally. Deep breath in. And out. And hold. Breathe normally. Deep breath in and hold, breathe away. And deep breath in and out and hold, breathe away. Okay, just lift your chin up a bit for me if you would. Deep breath in and hold and breathe away. Okay, stay forward for me if you would. I'm just going to have a look at your back now, okay? Deep breath in and out. 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 Just lie back for me. All right, I'm just going to have a look at your legs now. Okay, so I think all the symptoms that you've come with today are likely to be linked. The breathlessness, the heaviness in the chest, and the dizziness and the potential blackout are, I think, related to the main valve that comes off the heart, which is called the aortic valve. I think that valve's narrowed, and that's what's causing a murmur that I can hear when I listen to the chest. All right. We need to do some more tests to confirm this, so we're going to send you for an ultrasound scan of the heart called an echocardiogram. All right. And once we've got those tests, then I'll have another chat to you and we'll talk about any treatment options that may be required. All right?
Yeah.
Has that addressed all of your concerns?
At the moment, yeah.
Good. So to complete my examination, I would like to check the patient's blood pressure, do a bedside ECG, and also a urine dip.
Thank you.
Thank you.
Can you summarise this case for me?
So this was a case of Mr. Cooper, who is a gentleman who for the last 6 or so weeks has been suffering with increasing breathlessness, particularly on exertion. He's been struggling to walk around the golf course and maintain his garden. The breathlessness has been associated with a heaviness in the chest, and he's also noticed at peak exertion some episodes of dizziness and one episode of a loss of consciousness. On examination, there was an ejection systolic murmur which radiated to the carotids, and there was a slow rising pulse centrally. I believe this is all in keeping with a diagnosis of aortic stenosis.
Are there any other causes of a systolic murmur?
Yes. So first of all, it could be aortic stenosis, like I've said. It could be a mitral regurgitation. It could be a mitral valve prolapse or a ventricular septal defect. Though in this case, with the gentleman's age, I think a degenerative aortic stenosis is most likely.
And how would you ascertain clinically the severity of his aortic stenosis?
So from the clinical examination, there are some clues which can guide us towards the severity. The first of which is the nature of the central pulse. If you have a slow rising central pulse, that usually suggests that this is a severe aortic stenosis. Also, the presence of evidence of left ventricular failure would also be in keeping with a severe aortic stenosis.
And how would you investigate this gentleman?
So, first of all, I would like to do an ECG, looking in particular for a left bundle branch block pattern or evidence of left ventricular hypertrophy. Then I would like to do an echocardiogram, particularly looking at the continuous wave Doppler across the aortic valve.
And how would you manage this gentleman?
Given that this gentleman is symptomatic and I'm concerned about severe aortic stenosis, I think he would likely require referral for valve intervention. Prior to any valve intervention, he needs some further testing. So as well as the echocardiogram, he'll need lung function testing, carotid Dopplers, and a coronary angiogram. And then there are two kinds of valve intervention available. The first is valve replacement, which is done surgically through a midline stenotomy. There are two types of valve replacements that can be done, either a metallic or a bioprosthetic. Metallic valves last longer, but they require warfarin therapy, and bioprosthetics don't tend to last as long, but you do not require anticoagulation. The other option is a TAVI procedure, or a transcatheter aortic valve intervention, where we go in femorally and replace the valve that way.
How would you decide if this gentleman was to undergo an open procedure or a TAVI?
The decision is usually made in an MDT fashion. That MDT usually involves interventional cardiologists and cardiothoracic surgeons. Usually the TAVI procedure is reserved for the more elderly patients who would be unlikely to survive the general anaesthetic and significant recovery time that is required for open heart surgery, though evidence is still or research is still ongoing into TAVI procedures in the younger population.
Thank you.
Thank you.
The initial history leads to a very wide differential diagnosis, each of which should be explored fully by asking the relevant questions. A thorough exploration of the character and radiation of the chest pain, together with the onset and severity of the breathlessness, would be expected to be expanded on fully. The symptoms of dizziness and the possible blackout were ascertained well. Following this verbal interaction, the main area to concentrate your examination on should be apparent. In this case, it is pointing towards a more cardiac cause of symptoms, but equally, if the history was more respiratory, then that should be the focus. In reality, as here, the candidate focused mainly on the heart, but did listen and percuss the lung fields. The examination findings were that of classical aortic stenosis, with a slow rising pulse and ejection systolic murmur in the aortic area, radiating to the carotids. This fits very well with the symptoms and brings the case together. The candidate would then assess the severity clinically by looking for any cardiac decompensation or signs of pulmonary hypertension. Any peripheral signs of endocarditis should be looked for. It is worth noting that a loud murmur does not necessarily mean the gradient is severe, but conversely, a quiet murmur may actually represent very severe aortic stenosis, with a weak left ventricle unable to generate a good flow over a tight valve. The patient's concerns must be addressed as demonstrated here, and the plan for investigation and potential management options may be explored.
Good morning.
Morning.
My name's Dr. Farrant.
Nice to meet you.
Can I just confirm your name, please?
Stephen Fletcher.
Nice to meet you, Mr. Fletcher. What have you come to see me about today?
For about a month, about a month ago, I started to get a lump in my throat, and it just hasn't gone away.
Hasn't gone away?
No.
Okay. So is it just on one side, or have you got lumps on both sides?
It's just on the one side of my throat, just on the right.
Okay. And have you been feeling unwell with it at all?
No.
Not really. Okay. What about, have you had any sort of coughs, sort of sore throats, runny nose, anything like that?
Nothing that I can think of.
Okay. Headaches?
No.
And what about sort of weight loss at all? Have you had any of that?
I have actually, because I keep up quite a healthy gym habit.
Right.
And I stay on that kind of thing, so I'm always not quite aware of how much I'm weighing, and I have noticed a drop off in weight.
You've dropped off.
Yeah.
Okay. And is that something, you say you're a fairly active person. Have you been trying to lose weight with it? Or?
No, I've not been trying to do anything in particular. I've just been doing my usual routine.
Usual routine.
But whereas my weight once stayed constant, it's now starting to drop off a little bit.
Have you noticed your breathing's affected at all?
No.
No. Okay. Has your appetite changed? If you're losing weight, do you think you've been eating less?
I know my appetite's been the same. I haven't really changed anything. My lifestyle hasn't changed at all.
And are you sleeping all right, or?
Well, I've been sleeping fine. I can get off to sleep fine. I sleep fine, but nearly every night I will wake up throughout the night and just completely drench the bed through with sweat.
Okay.
Happens quite regularly.
Every night, okay. I mean, it has been quite hot recently. Do you think this is sort of an abnormal amount of sweating?
I think so, yeah.
Okay.
Because I've been sleeping in a cooler room. I've been trying to make the effort to change how I'm sleeping, but still the same.
Right. Okay. What are you worried about?
Well, when my mum was younger, she was diagnosed with bowel cancer.
Okay.
And I don't want to jump to any conclusions, but I'm a bit anxious that I've inherited that from her.
Right.
Mm-hmm.
Okay. The first thing I would say is that I think it's unlikely to be cancer, just because of your age in particular. you know, the older people get, the more likely they are to develop cancer, and you're, you know, a fairly young gentleman.
Okay.
But it's something that certainly, you know, we'll do some more tests and look into in more detail. I've got some more questions to ask you first, though, just so that we can, you know, I can get a better picture of how, you know, where you're at.
Mhm.
Okay. So, have your bowels changed at all?
No.
They've been about the same.
Everything, yeah.
Good.
Sort of,
Okay.
yeah.
Passing water all right?
Yes.
Okay.
Mhm.
Not noticed any discoloration of your urine or anything like that?
No.
Okay. Good. And you've not been vomiting at all?
No.
Okay. Good. And do you smoke?
Up until about a year ago,
Mm-hmm.
I used to smoke. I was never a 20 a day bloke. I was more of like, you know, 5 to 10 a day. I was never very committed. But I quit almost a year ago.
And how much alcohol do you drink?
Only on the weekends, on like a Friday, Saturday, go out, have maybe 6 or 7 pints.
Okay. Do you do any? Do you take any over-the-counter medications?
The only thing I really take is paracetamol. I don't really take anything else.
Okay. You're not prescribed any regular medications?
No.
Okay.
Mhm.
Do you do any illicit drugs?
No.
Okay. Let's just go back a little bit to some of the symptoms you were talking about. And you said you were getting night sweats.
Yes.
Is that happening every night?
Near enough every night, yeah.
Near enough every night.
hmm
Okay. And are you having any fevers?
No. No.
Okay. So it's just at night that you're noticing you're sweating. You're not sort of abnormally getting really hot during the day.
No, it doesn't happen during the day.
Okay. And what about the weight loss that we were talking about? How much weight have you actually lost?
I think about 4, maybe 5 kilos.
Okay. And over what sort of a time period is that?
About a month,
A month
6
or 2?
weeks, yeah, about
Right.
that, yeah, something like that.
Okay. And have you noticed any other abnormal symptoms? Anything else that you just think is out of the ordinary for you that you want to just sort of let me know about?
I think I've covered everything.
You've covered everything.
I think so, yeah.
Okay. And what job do you do?
I'm a personal trainer.
You're a
in
personal
gym.
trainer?
Yeah.
Okay. And has all of these symptoms sort of affected your ability to do your job and stuff?
More just not physically. I certainly feel a bit of a difference in strength, but I feel okay, like in my head. Like I'm still fairly enthusiastic about work.
But you're just sort of worried and
yeah. The stress is a little bit.
Yeah,
it's affecting me.
I can understand that, but I think you've done the right thing by coming and speaking to me today.
Okay.
Certainly, it's important that if you're concerned about something, you come and you get some more advice about it.
Yes.
All
good.
right. What we're going to need to do now is do some more investigations into it.
Okay.
So first of all, what we're going to do is I'm going to get you on the couch. All right. We'll get you to take your shirt off.
Okay.
And then I'll do a full examination of you, just to first of all get a feel of the lump.
Yeah.
All right. And then we'll just check any of the other areas where you can have lymph nodes. Because it sounds like it's a lymph node, but until I have a feel of it, then I'm not going to know what's going on. And then I'll have a sort of a quick examination of the rest of your symptoms, have a quick listen to your chest, and have a feel of your abdomen. All right, and then we'll go from there. After that, it's probably going to be some more tests, but I'll talk to you about that in more detail once I've finished examining.
Okay.
You. Is that all right?
Yeah, sounds good.
Brilliant. Okay, so I'm just going to have a quick examination of you now. All right. So first of all, can I just get you to take a nice deep breath in for me, please, and out. And give me a cough. All right. Can I just have a look at your hands, please? Okay, and turn them over. And back over for me. Relax that hand down. Let me just have a look at this one. Okay, I'm just going to feel your pulse now. Relax. Rest your head back and look towards the wall for me. You got any pain in your abdomen?
No.
I'm just going to press on it. Okay. And I'm just going to feel the pulse in your neck now as well, alright? That's great. Can I just get you to pull down on your eyelid for me as well? Okay, and relax. And if you could just open your mouth for me, please. Let me just have a look. Okay, and just relax your tongue now for me. Say ah. Okay, and let me see the bottom of your tongue. Thank you. So I'm just going to have a quick look at your armpits now, all right? Okay. All right. I'm just going to have a quick listen to your chest now. Okay. And sit forward for me if you would. I'm just going to have a listen to your back now. Nice deep breath. And out. And again. 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 And out. Okay. Have a feel of your neck now, alright? Okay, stick your tongue out for me and bring it back in and give me a swallow. Okay, that's good. Okay, fine. Stay sat forward. I'm just going to lay the bed down. And lay yourself back down for me. So I'm just going to have a quick look at your abdomen now, alright? So when we were talking about some of the symptoms you've been suffering from, just a few other questions.
Okay.
Have you noticed you've been itchy at all?
No.
Okay. And have you been on any trips abroad recently?
No.
Okay, good. You're not allergic to anything, are you?
No, no allergies.
Okay, good. Okay. Nice deep breath in for me now. And out. And again. 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 And out. Okay. Okay, fine. So, just roll towards me slightly if you would please, and roll back now. And roll the other way for me, and back down. Okay, fine. Okay, just going to have a look at your ankles now, all right? Okay, we'll just sit you up now, all right? And relax yourself back. So there are two things that we've found, all right? First of all, you certainly do have a swelling in your neck, all right? And the other thing that I can feel on feeling your abdomen is it feels like there's a sort of a lump there, just on the left side, all right, which might be your spleen. So we need to do some further investigation into that.
Okay.
All right. Once the sort of investigations I'd like to do are, we'll do some blood tests. All right. We'll do an ultrasound scan of your abdomen just to have a look at this and see if it is the spleen that's enlarged, and if it is enlarged, measure it. And then we may need to take a sample of the lymph node in your neck. Once we've got all of those tests done, then I'll come back and have another chat to you about what it might be.
Okay.
All right. Thank you. So to complete the examination, I would like to examine the groins for further lymph nodes, and I would like to do an external genital examination with the patient's consent and a chaperone present.
Can you summarise the important aspects of this case?
So Mr. Fletcher presents with a 6-week history of unilateral neck swelling, night sweats, and about 5 kilograms of weight loss. He has a family history of bowel cancer on his mother's side, and there were no other positive findings coming from the history. On examination, he had approximately 3 by 2 centimetre right-sided neck lump, which didn't move on swallowing or tongue protrusion, and it didn't appear to be tethered. He also had 4 centimetres of palpable splenomegaly, and there were no other significant findings on examination.
What would be your differential diagnosis here?
So, in a patient who has had splenomegaly, there is a large number of possibilities, though with respect to this patient who is young, I think there are sort of a couple of things that are more likely. The first of which is that this could be an infection. So this could be infectious mononucleosis or glandular fever, or this could be from a hematological problem, such as a lymphoma or a leukemia. But further investigation is required to elicit the exact cause of this patient's splenomegaly.
And what investigations would you perform?
So first of all, I would like to do some blood tests. So I would want to check the patient's full blood count, particularly to try and check the bone marrow function in case this was a leukemia. I would also want to do a blood film. I want to check the patient's urea and electrolyte levels. And I'd also want to do a monospot test to look for the infectious mononucleosis. Then going forward, I'd like to do some more scans of the patient. I'd like to do an ultrasound scan of the abdomen to sort of assess the splenomegaly more. First of all, to confirm that it is an enlarged spleen, and then secondly, to measure the size of it. I would also want to do a CT scan to look for further evidence of lymphadenopathy, particularly looking for mediastinal lymphadenopathy. Other things that we could consider going forward would be a PET scan to look for areas of sort of active lymph nodes, or we could do a biopsy of the lymph node in the neck to get a proper tissue sample.
You mentioned getting a biopsy from the lymph node. Would an FNA or a fine needle aspirate be appropriate here?
So it would very much depend on whether cytology or histology is required. For a diagnosis of lymphoma, histology is more appropriate, and you cannot get an adequate sample for histology from a fine needle aspirate, only for cytology. Therefore, I think it would be more appropriate for us to do a biopsy in this case so that we could get an adequate sample size for histological assessment.
If the lymph node biopsy report came back as showing granuloma, how would you interpret that?
So firstly, I would be steered away from the differentials that I've already mentioned. Granulomatous disease is not classically associated with glandular fever or with hematological malignancies. I would be steered more towards a diagnosis of either tuberculosis or, more importantly in this case, I think sarcoidosis. The reason for that is that tuberculosis is not classically associated with splenomegaly, but sarcoidosis is. Therefore, to investigate this further, what I would like to do would be to get a chest x-ray for this patient to look for bilateral hilar lymphadenopathy. I would also want to do blood tests to check the patient's calcium levels and check their serum ACE, although this is not very specific. And I would like to send the patient for lung function testing.
Thank you.
Thank you.
On an initial inspection, one may notice the bruising around the patient's eye. This was related to trauma and not relevant in this case. The differential diagnosis here is wide-ranging, from a mild self-limiting diagnosis of glandular fever to serious lymphoproliferative disorders. The history suggests possible B-type symptoms of night sweats and weight loss. Carcinoma was quite rightly put down the diagnostic list